scene.
We are on live in another 10 seconds.
Okay, moment you're live, you play the music. Moment we are live, the music ends, 11 starts.
Done.
11 are you there? 11 please report 11
She must be muted.
on the scene.
We are on live in another 10 seconds.
Okay. 11 are you there? We request all the audience, please mute your video and audio. Please mute your video on audio. If the video and audio is on and we force muted for 4 times, 5th time we'll have to make you to go back to the waiting room. Please mute your video and audio, all the audience.
I'm in.
Be here. We don't go anywhere.
We'll start with the Mentimeter. Anyone, can you open your screen, please, for the Mentimeter app for the code?
Sure. 1 sec. You have to help me share the screen. Can I?
Yes. Praveen, let 11 share the screen. Sankarshan, please mute your audio and video, please. Request all participants, please mute your audio and video, please. Please mute your audio and video, please. 11
Yes.
Praveen, can you let 11 share her screen?
Yeah, she can now.
11 you can share your screen, please. Pramod, come in, Pramod.
I'm not able to share. 1 second.
I'm here.
Okay.
I can hear them.
Praveen, check 11 screen, please. She's not able to share.
She can.
Okay.
Now can you see this?
Yes. All the
Please go.
participants for the Mentimeter code for today is 969519. I repeat, Mentimeter code for today 969519. Request all the participants, please log into mentimeter.com or the app you have and enter the code 969519. So we wait for 1 minute for all of you to enter the code, and once after that, Dr. Elevenil will start with the quiz for the day. Elevenil, you're ready?
Yes, I'm ready.
Please take over. You can repeat the code.
So here we go.
When you'll wait for 30 seconds. When you'll wait for 30 seconds.
I'll see
No, it's okay. You let this run. Okay.
Yeah.
But give more time for the first question.
Yeah,
The YouTube people are only just hearing it now. Yeah.
Right.
Yeah.
This has about 90 seconds.
Yeah. Should be good.
Yes.
Vinil, can you repeat the Mentimeter code in case anybody is just joining
Okay,
after this question?
the code is 969519.
Mustafa sir, you cannot share your screen now. Mustafa sir, you cannot share your screen now.
Praveen, come in. Stop Mustafa's screen sharing, please. Elevenil, share your screen again.
Yes.
Participant, please mute your video and audio, please.
So 42 out of 94 have answered it right. And this is the correct answer. Increase in nasolabial angle. We move on to the next question. So 38 have been right. The correct answer is ascending pharyngeal artery. We move on to the next question. So 37 are right. The correct answer is undermining the oral mucosa from the orbicularis oris till the wet line. Next question. Time is up. 61. The answer is possibility of torque on the condyles. Next question. The answer is soft tissue adaptation.
Elevenil, can you repeat that score? Elevenil, are you there?
Previous score, 51 of them got it right, Pritam.
We have the maximum number of participants for this question. "19 have got it right. The correct answer is 9 months before the surgery. That was the last question. Pritam sir, you're done with the quiz.
Thank you, Elevenil.
Yeah, thank
Pramod,
you.
Praveen, stop sharing Elevenil's screen, please, and allow me to share my screen.
Pritam just mentioned that there will be a post test as well, which will be based on questions from the lecture.
Yeah. Requesting all audience, kindly mute your audio and video. Audience on Zoom, kindly mute your audio and video, please. Audience on Zoom, please mute your audio and video, please.
And keep it muted throughout. Just know that if you go out and come back in, your audio remains on, okay? So when you come back in, if you, in chance you go out and get back in, please ensure that again your audio is muted and video is off.
Good evening, everybody. Before I introduce our co-host for the day, I also want to share with you, we have decided to have what on the April 18th, which was supposed to be a free day, we decided to share AOMSI Got Talent. So all the participants here, you can kindly record any of your talents like singing, dancing, Like Pramod, you want to talk about push-up?
I've already started practicing.
Yeah, yeah.
100
Pramod has started
push-ups.
practicing 100 push-ups in 3 minutes. So anyone want to challenge him? Kindly do 100 push-ups in 3 minutes. Make a video and share it. Please send it to me or email it to secretary@aomsi.com by tomorrow. On 18th, we'll come live to share all the talents. We'll have Dr. Borle with us, who will be singing for us. Dr. Mustafa, Dr. Amit will be singing. We have Dr. Pradeep Christopher, who will play play the instruments, and we have Dr. Ravi Hebali, who's going to show his talents on photography. So coming back to AOMSI Series 8, welcome you all. For today, we have, as usual, we have co-hosts on YouTube. We have 2 co-hosts on YouTube. Dr. Padmaraj. Padmaraj, you want to say hi? Dr. Padmaraj?
He must be muted, I think. Wait.
Hi, everybody.
Yes, Dr. Padmaraj, and we have Dr. Jayesh. Dr. Jayesh. So all the participants on YouTube, kindly pose your question to Dr. Padmaraj or Dr. Jayesh. Please avoid discussing among yourself on YouTube. Dr. Padmaraj or Dr. Jayesh will answer your questions if they can on YouTube. If not, they'll pass on to the co-host in the Zoom, who will in turn ask to the speaker of the day. On Zoom, we have 2 co-hosts for the day. Padmaraj and Jayesh, you can go to YouTube, please. You can mute your audio and video. For the day, we have Dr. Vivek Vardhan Reddy. Again, doesn't need any introduction. Vivek sir, you want to say hi to the group?
Yeah. Hello, everyone. Thanks,
And
AOMSI, for this opportunity.
And we have Dr. Kotrashetti from Belgaum. Again, doesn't need any introduction. Kotra sir, you want to say hi to everybody? Abhay, please mute your audio, please. Kotra sir, you want to unmute yourself and say hi to everybody? Okay, we have Dr. Kotrashetti from Belgaum, who will be the other co-host on Zoom. We have 2 speakers for the day. Both the speakers are very special to me and Pramod. So we decided to host this particular AOMSI Series 8 together. Let me start with introducing our speaker, Dr. Abhay Kamath, who actually doesn't need introduction. Pramod told me I have to introduce him in 1 line. And if I have to introduce him in 1 line, he is an example for perfection. If Abhay Kamath comes to present any lecture, for every slide, he'll have 2-page notes with him well in advance. That is Dr. Abhay Kamath for you all. So any one of you have any doubts, this is the time to clear it. Abhay is here to answer you all. Our second speaker for the day, Dr. Mustafa, can you please on your audio and video, please? He is Dr. Mustafa. He is very special to me and Pramod. So we decided that he'll have 2 parts of introduction. I will introduce Dr. Mustafa as a person, what he is, to me and to rest of us who are his friends for ages now. And Dr. Pramod will introduce Dr. Mustafa on his academic side. So if I have to introduce Dr. Mustafa in a very short note, the Prime Minister of our country announced, light a lamp. See the perfection in this man. He lit a lamp with physical distance. 2-meter physical distance between each lamps. That's Dr. Mustafa for you. Today, if you guys are going to listen, you're going to listen to a speaker who is going to have this level of perfection. So, ladies and gentlemen, kindly ask your question. Pramod, over to you.
Thanks, Preetham. Both these speakers today are very close to me. Abhay, we have known each other for 20 years plus, and very close friend. We have grown together in academics as well. And Dr. Mustafa has been a teacher first. He taught me during 3rd year BDS. I always say that he is a person who inspired to take up surgery. And then he has been a mentor and recently very good friend. He has changed the way we have started learning. I say started learning again because of the way he has incorporated learning on social media. He started this AOMSI Cleft group, and he started putting his own cases and discussing and thinking, making people to think about, scenarios. And so it has changed. We learn something new every day from his own efforts. And it has also encouraged us to, move in the same manner and try to teach others as well, along with the learning that we have had. And this is one opportunity. And one thing, if I can say about Dr. Mustafa, is that he never does something half-heartedly. If he has to do something, he will do it with his full heart and full effort. And that's what we are going to listen to today. Over to you, Dr. Mustafa.
No, stop. I have to come on the screen. My face has to come. Can you all hear me?
Yes, clear, sir.
I can't see myself.
Yes, sir. We can hear you. You can start, sir. You can see the screen only.
I have to come then. Yeah. Good afternoon, everybody.
Good afternoon.
First and foremost, I would like to thank the Association of Oral and Maxillofacial Surgeons of India for giving me this great opportunity to connect with the larger audience. So my immense gratitude for the same. So before I begin, I would like to touch upon what do you mean by concept? Concept is nothing but an abstract or an idea. It evolves a thorough process. It involves a thorough process, or not evolves, involves a thorough process of thinking. The abstract idea needs to undergo a process of evolving and scrutinization to make it acceptable. So, when you are confronted with a skeletal malformation of the face, there is always a tendency to underperform or indulge in what is termed as an overkill. So I have put this slide to depict it's a Greek mythology of Scylla and Charybdis. Okay, so Scylla is that monster, and Charybdis is that whirlpool, and you have to pass through both of these extremes to reach your destination. And in the Greek mythology, Odysseus achieved that. Of course, in the bargain, he lost a few sailors. So that is the analogy I will quote. But to strike a balance between underperformance and overkill, one needs to understand the concept leading to acceptance. And finally, what is important is executing it skillfully. So the first thing that I'm going to talk about is mandibular setback. It is not a concept, it is a procedure. So what is important in this context is to understand how much setback is feasible. So you have this article by Egensperger in 2004, which says that you can do a setback for 12 millimeter and it is quite stable. Okay. In my own experience, I have done around 14 millimeters of mandibular setback, and that particular case, it was quite stable with a millimeter or two of relapse. But what is acceptable is a mean setback is of 6.4 mm is considered to be stable. Now, it is not only stability that we need to take into consideration, but there are other factors which are important when you plan a mandibular surgery. Now, for example, this patient, I did a setback of around maybe 6 to 7 millimeter, and that is the post-operative result that you can see there. I've just done a BSSO for this, and that is the settling of the occlusion. But what you need to understand is what happens when you do the setback. When you do the setback, there is a possibility of the anterior facial height increase. Okay. There is also a possibility of a change in the lip-chin-throat angle. The lip-chin-throat angle in mandibular prognathism is acute. It becomes more obtuse, but how much obtuse it should become. So that is what is important. So we need to take into certain aesthetic considerations like the cervical length. That is what it means is the neck, if it is short and stout, it may possibly lead to a double chin, and that is considered aesthetically unpleasant. Okay. Gassemi et al. In 2014 noted there is a significant change in the lip-chin-throat angle in the group with mandibular setback of as minimum as 5 millimeter or more. So how much does it change? The lip-chin-throat angle will change by 7 degrees if it is less than 5 millimeter. In the group which is more than 5 millimeter, you can expect a change of 10.2 degrees. So when this changes, it can be aesthetically unpleasant. Okay. So Arnett et al. Suggested that it is imperative to consider a combination of clinical, facial, and soft tissue cephalometric as an effective guide in treating mandibular prognathism, not just taking the occlusion into consideration, because very often the amount of setback is decided by the occlusion because you have an existing class 3 occlusion, and that may require a considerable amount of movement. This is another article by Egensperger, which says that whenever you do a setback, there is thickening of the soft tissue at the pogonium. And Ho et al. Says that for a mean of 9.4 millimeter of mandibular setback and 5 millimeter of vertical, there will be a 5.1 millimeter of osseous chin reduction. So in a gist, what I would say is, whenever you do a setback, there is likely to be a lower facial height increase. There is likely to be a change in the lip-chin-throat angle, which at times could be unaesthetic. So to counter that, what would you do? So one of the ways that we could address the problem is by doing a simultaneous genioplasty, so that we can reduce the lower facial height. This is a case where we have done a BSO and a genioplasty together, and that's the postoperative result. Look at the profile and look at the lip-chin-throat angle. We have been able to restore the same lip-chin-throat angle as it was in the preoperative phase. It has become a little more obtuse, I would say. That is the X-ray findings, and that is the occlusion we were able to settle. Now here is another case where mandibular setback alone was done. Now, if you look at this case, you would see that the lip-chin-throat angle is become more obtuse. And you can see the sagging of the tissue in the submandibular region. So there is a potential in this case for developing double chin. That is the, and if you see the postoperative X-ray, you would see there is a slight increase in the lower anterior facial height. Coming to mandibular advancement, okay, what is feasible is around 7 millimeter, okay, is essential when it is treated with rigid fixation. So in patients with a high mandibular angle, large advancement relapse is seen despite the use of rigid fixation. So in terms of stability, advancement is a little more prone for relapse than setback. So here is this another case who came to us with a complaint. His complaints were different. He wanted, basically, he didn't understand what he exactly had. He had wanted, because he's a gym model, he wanted to have a very chiseled jaw. But when we examined him, what we noticed is he had a it was a class 2 case with a retruded mandible plus an increase in the intergonial width. So that is how he was in the preoperative phase. Look at the gonial angles. He's almost got a square face. Along with a class 2 occlusion, he has lost a couple of teeth. And that is a cephalometric and preoperative PSF. You can see the projection of the gonial angle there. And that's him. He's got a very chiseled body. So he wants to match his face with his body. That was what his request. So what we did in this case is we advanced the mandible by around 6 to 7 millimeter, because you can advance as much as the occlusion will permit you, not more than that. And then we also advanced his chin and downgrafted his chin. In the sense, we did a chin inferior reposition. So that is the postoperative result. You can see that the proportion between the bizygomatic width and the bigonial width we have been able to restore. And this is the pre and post cephalometric, PSF. You can see that the bigonial width has significantly reduced. So when we did the BSSO, what we additionally did was an angle ostectomy. So we removed his angle. So that gave the reduction in the intergonial width. So that is the preoperative PSF imposed on the picture. That's the difference that you can see there, how his bigonial width has reduced. Look at the projection he's got as far as the chin is concerned. Overall, his face, which was appearing to be short, appears to be elongated. And that is the profile view. And superimposition again of the profile picture with the lateral ceph. And you can see the significant change that we have been able to achieve in this case, where we have done an additional procedure of doing an angle ostectomy. That's him. That's the occlusion. He's still undergoing orthodontics. And look at the angle. You can make out in the post-surgical, if you look at the ramus carefully. Let me get the cursor here. Can I? Okay. See, what we have done is we have done an ostectomy here in the angle from here, like this way. Okay, we planned it very well and then removed it. So that's him. So besides this, there are other things that we need to take into consideration. That is the gonial angle, which plays an important role in ensuring an harmonious facial profile. So there is this contention between what is good, whether BSSO reduces the angle more or a VRO, vertical ramus osteotomy. So this particular study by Yardani says that it is better when you do a vertical ramus osteotomy. But there are other articles by Tabrizi et al. Which says there is no difference as far as the change in gonial angle is concerned, because you should remember, in a prognathic mandible, the gonial angle is very obtuse. So the idea is to make it a little more acute. And another, the same article says that there is no significant difference between IVRO or BSSO is noted as far as the gonial angle change is concerned. So a couple of examples to see, to demonstrate how the gonial angle changes when you do a mandibular setback. So these are some aesthetic considerations that you have to take into account when you do a mandibular setback. And here's the same patient which I showed earlier. Look at the change in the gonial angle. Okay. Now, coming back to this debate of whether IVRO is good or BSSO is better. So in IVRO, according to Gali, there is lower incidence of inferior auricula nerve injury. It's technically simple. That's what he says. And there is an ability to reposition the condyle. The disadvantages, which is significant, is the need for an intermaxillary fixation and excessive medial stripping. Whereas in the BSSO, one of the main disadvantage is the neurological injury that is likely to happen if you're not very careful. And I would subsequently tell you how you can avoid it. Even the fixation adds to the incidence of associated nerve injury. And there is sometimes, if you're not very careful in using your osteotome, there is a possibility of an unfavorable osteotomy. The advantages, it has a large area of bony contact, okay, which allows rapid healing, therefore improved stability. And the most important aspect is immediate post-operative mobilization. Besides this, I would like to add one more point. It is much more versatile. For example, if you want to do a slight anti-clockwise rotation of the mandible, it is possible with the BSSO, because if you do it in IVRO, you may get a step there. The same thing with any kind of rotation of the mandible, BSSO has an advantage. For example, if you want to slightly superiorly reposition the mandible, if you do an IVRO, you may get a step there. So BSSO has that versatility in terms of the technique. But why I'm making this point is, I remember way back in 2015, 5 years ago, one fine afternoon, my former boss and mentor Kishore Naik called me and told me that, Moose, stop doing BSSO. I'm just back from the United States of America, and there's this big hue and cry. There are a lot of patients who have undergone BSSO and have landed up with sleep apnea. So that made me to consider whether I should be doing IVRO. I did give it a thought, but coming back to the point whether you can avoid nerve injury, these are some of the measurements. It is 3 millimeter away. If you look at mediolaterally, the nerve, okay, and it is around 7.5 millimeter away from the inferior border. And you can see this, one second. Yeah. I hope my cursor here. So into the area where you have done the cut, this is the cut that you are likely to do.
So your cursor won't be visible in full screen, sir. You will have to minimize the window and then use the full screen and then use the cursor.
Okay, can I
just go out of presentation window whenever you want to use the cursor.
Okay.
And once you have finished that, come back to presentation view.
Okay, we just minimize the thing. Stop sharing.
Go out of presenter view.
Go out of presenter view.
Actually, everybody is telling that they can see the cursor even when you are using the full screen.
I think you can go ahead without any change.
Yeah. Okay.
All the participants are messaging.
Okay. Right. Yeah.
Okay. Then I'll go ahead with the presentation. Just go back to the form slide. Okay. So what I personally do, and I'm sure many of them must be doing it.
Sir, you need your earphones back, please.
Okay.
Okay. Am I audible now?
Yes.
Okay. So this is something which I thought I would do, but subsequently I realized that many of them follow this technique, because the other day I happened to be talking to Dr. Kannan. So he said he also does the same thing. So what I do is, instead of doing a straight osteotome, I do what you call, I use a, one second. Okay, now the cursor is visible. Okay, I use the curved osteotome, which will conform to the contour of the mandible in a superior inferior direction. And when I drive the osteotome, what happens is most of the cancellous bone will go onto the distal segment, so that the nerve has a sliver of cancellous bone around it. Many a times I have witnessed that the nerve is not visible at all. The nerve is gone completely medial. And besides that, what I do is I also open it up with a curved osteotome. Okay, I open it, I put the curved osteotome even in this vertical cut here and try opening it like a window. Sorry, here. One second. Yeah. I use the same curved osteotome here in the vertical cut and open the window there. So these are some of the minor small maneuvers, I would say, which can, to a great extent, avoid nerve damage, which people are very skeptical about. So coming back to this airway considerations, what Kishore happened to mention at that point of time, I went and looked into the literature.
Sir, if I can come in, please. I think your voice is again gone low. If you can keep your earphone mic close to your mouth, please. The audience say that
is it better now?
Yeah, it's better now. Or if you can increase the output volume, please.
No, now is it better? Because I've got it very close.
I think it's better now. Thank you.
Yeah. Okay, thank you very much. So this prompted me to do some literature search at that time. Should I switch over to IVRO? And what I found is that mandibular setback, though it reduces the pharyngeal airway space, there is very little evidence confirming post-surgical obstructive sleep apnea. Nevertheless, there is a risk in a particular kind of patients, okay? And this has to be viewed seriously. But the evidence is moderate, okay? That being the case, okay, what we need to understand is if you do a genioplasty, there is a larger gain possibly in the hypopharynx, okay? Having said that, those patients who have a high BMI, if you do a mandibular setback, that will reduce the posterior airway space, and they are susceptible probably for OSA, not otherwise. Okay, and also advancement genioplasty would negate the effects on the posterior airway space decrease. So that is one point in favor of doing a mandibular setback and genioplasty. Not only that, it would also restore the corpus length you would have lost by the setback. So going a little further, so that is all about mandible, whether one should do a mandible alone or a bijaw surgery. So et al. Suggested that restricting the amount of mandibular setback by simultaneously advancing the maxilla contributes towards stability. So from a stability point of view, bijaw is better. Gassemi et al. Said in 2014, if the amount of maxillary advancement is increased during the double jaw surgery, it will reduce the need for an extensive mandibular setback, which can, as I mentioned earlier, influence the aesthetic and functional outcome. So cases treated, this is another article by Kanwal, Shetty, Varghese, I think it is Varghese Mani. Cases treated with bijaw surgeries had a significant soft tissue improvement in long term compared to mandibular setback surgeries. Therefore, there is a significant reduction in the airway problems that I just cited. Therefore, bijaw surgeries may be preferred overall in compared to mandibular setback surgeries alone. So here is one example. This particular patient was referred to me by an orthodontist, and he told me, sir, you should only do mandible. Don't touch the maxilla. I said, why? No, that is an enormous surgical challenge, surgical morbidity. So this is a problem which the surgeon, which the orthodontist have very often. When you say bijaw surgery, they are a little reluctant because many a times we need to educate them that orthognathic surgery at the present juncture is quite safe. The risks are quite minimized because of the technological advancement, improved anesthesia care, etc., etc. But still, they have this perception, including the patient. This patient was very particular that I do a single jaw surgery. And I did the single jaw surgery and look at the outcome. So 3 months after the surgery, the patient came back to me, and I had warned her well in advance. I told her, I am sure you will not be very happy if I do, the outcome will not be good. And eventually you will not be happy with the outcome. And that is what precisely happened. And 3 months post-surgery, she came back and she agreed to what I had proposed earlier. And she regretted that she should have undergone bijaw surgery. And subsequently, this is the occlusion that we got. You see, there is some amount of relapse, and it has come to an H to H kind of anterior relationship. So I subsequently did Elifort 1 and advanced the maxilla. Now here is the problem. This is what everybody needs to understand. Now here you can only advance as much as the mandible permits. It's the reverse thing what I said earlier. Probably if I would have done it in the first go as a bi-jaw surgery, her results would have been far better than what I have achieved right now. But nevertheless, she was quite happy with the result that we gave her, and that's her profile view. That's the occlusion. My orthodontist was able to settle it eventually. And that is the difference in terms of cephalometrics when you see a single jaw and a bi-jaw surgery. But it would have been far better if I would have done the bi-jaw surgery at one go and rather than facing it, because that was circumstantial. So this is another case, okay, where again, the orthodontist was very particular that I should do a single jaw surgery. I put my foot down and I said, I will not do a single jaw surgery on this case because I know what it could eventually lead to. You would complain if I have to do this surgery. So the message I'm sending across is sometimes you need to be a little firm in what you believe. Okay, so, but that doesn't mean absolute faith. Okay, I will come to that later. So I stuck to my guns, and the orthodontist relented rather easily. And I did a bi-jaw surgery, and that is the outcome. And look at the profile view and look at the occlusion. So I think this is enough evidence that if you do it at one go, the results are far better, and it could reduce the treatment time as well. And that is her x-rays, post-orthodontic decompensation and post-surgical. So now I would pass over to, so I have covered about basically about AP problems, that is anti-sagittal problems, I would say, where the need for a mandibular surgery, where there is a need for a bi-jaw surgery. But I would pass over to Dr. Abhay Kamath, who would speak on whether to do a rigid fixation or semi-rigid fixation.
So have you included the break in between, or do you want the course to?
No, he will finish this. It is for a short while, and after that, we will have the discussion.
Thank you.
Am I audible? Hello? Hello?
Hello? Yeah.
Yes, sir, Abhay, sir, you can continue.
Yeah. Am I audible?
Yes.
Am I?
Yes,
Yes,
you are.
Yes.
Yes, Abhay.
After the in-detailing talk by Dr. Mustafa, we need to remember that orthognathic surgery serves two unrelenting masters. That is, one is the hard tissue and the other one being the soft tissue. Sir has given an in-depth analysis of bi-jaw surgeries, mandibular setback, mandibular advancement. But however, all our surgeries, when we take into action, needs to be predictable and stable. When we look back into literature by Van Sickles, they have done studies where they have seen the advantage of using bicortical screws to see and compare with the use of plates so that they can minimize the rotation of the mandibular condyle when you do large advancements. They have compared both the use of bicortical and the use of plates. Bloomquist and Isaacson also compared three different modalities of fixation, where they came in with bicortical screws, monocortical screws, and plates. And they found no significant difference in the stability when we speak about in terms of fixation of the osteotomized segments. Next. This is a landmark article, probably when I first did my course in Narayana. I think Pramod was my mentor then, and he still is, where he introduced me to this article by Turvey and Phillips, and it's an open access article which is available on the net freely from the Head and Neck Medicine, April 2017, where it speaks about hierarchy of stability. When we speak about hierarchy of stability, you need to keep in mind that this is a flow chart which gives you an in-depth analysis of what is most stable, what is less, and what is predictable. So if you see this article, all maxillary movements directed towards the superiorly or in a forward direction are more stable and predictable. However, if the maxilla is moved forward or if there is correction of facial asymmetry in a sagittal direction, you end up with mixed results. So what you need to consider is when you have situations where you're treating combined movements of maxilla up, mandible advanced, it mandates rigid internal fixation. Paper by Bruce Epker dating back to 2008, where he speaks about comparison of wire fixation to that of mini plate fixation. The most important aspect what they spoke about was rotation or the inclination of the proximal segment. And the other aspect we need to touch upon is what is less predictable and stable. The most important concept here is when we do a maxillary down grafting or an inferior repositioning. And when you have a situation where you are playing with the maxilla in the transverse direction. Over to you, Dr. Mustafa.
Now, I think we will have a break for discussion about what we covered so far. And it is open for discussion. And I want the other co-speakers to conduct this discussion on what we have spoken so far.
Thank you, Mustafa and Abhay, for a wonderful discussion. I have a few questions from the audience. Let me ask Mustafa. The first question
is, please tell.
What are the changes in soft tissue pogonian in mandibular setback? When do you consider doing a genioplasty? Do you always consider it, or please?
So basically the question is when you make a decision to do a genioplasty, okay? Off lately, I would do a minimal amount of genioplasty in all the cases, majority of the cases, unless and until they have already a well projected chin, a good mentolabial sulcus, mentolabial sulcus, that's the right word. So if it is pre-existing, then I would not do it, but otherwise a minimal amount of what is called as superior repositioning of the chin, I would consider for every single case because of the reason of increase in the lower facial height. So I would get the chin a little forwards and upwards, like probably the phenomenon of autorotation, which I will speak later. So that is what I would do. Maybe people would think about it differently, but in recent cases, whatever I have done, most of the cases I would do the chin.
Okay. Second question to Mustafa. What is your personal choice in mandibular setback, BSSRO or IVRO, and why?
As I mentioned earlier, I had contemplating doing IVRO when Kishore came, and he's my mentor. So whatever he says, I would rather take it seriously. So I I thought I'll try it out. So first I tried doing it on a sheep's mandible. Then when I looked at the literature, I found whether there is actually a need, considering the pros and cons. I think BSSO still is a versatile technique because of the various other disadvantages of doing IVRO. You have to put the patient on IMF. Of course, these days people are doing the fixation, direct fixation, after doing an IVRO with a angled plating device where the whole armamentarium is angled, so you can go and do the fixation. Despite that, I don't think it has the necessary versatility that BSSO has. So I would stick on to BSSO and not switch over to IVRO. As of now, no. In some cases, I have done an inverted L osteotomy, which I would discuss subsequently. But standard, yes, BSSO.
Okay. With your permission, Mustafa, for the benefit of the youngsters who are watching this, what I would consider is, I would discuss the pros and cons with the patient whenever they come to me, basically for the correction of mandibular prognathism. I would say on one side, you have the complication of altered sensation of the lower lip. On the other side, you have the disadvantage of being on maxillomandibular fixation for 4 to 6 weeks. Which one you prefer? I ask the patient that question and give a choice to the patient, provided I have very good retractors to do an intraoral vertical ramus osteotomy. Because when we were trainees, say 25 years back, we were doing extraoral vertical ramus osteotomies, but that would leave the patient with a bad scar in the neck and possible damage to the marginal mandibular branch of the facial nerve. But with the advent of intraoral technique, that is completely avoided. The only problem is maxillomandibular fixation for 4 to 6 weeks. That too, if you want to avoid fixing these osteotomies with the transbuccal trocar system. If the patient says, doctor, I don't want any kind of altered sensation in the lower lip, but I don't mind being on maxillomandibular fixation for 4 weeks, then what would be your choice? Dr. Mustafa.
This is a question or a comment by you?
It's a comment also and a question also, both.
Yeah, so let me ask you a counter question now, since you have asked this question to many of your patients. What was the answer, whether they chose IMF or they chose a possibility of nerve damage?
Well, probably many patients said, I don't want any IMF. I want to return to the function as early as possible.
Exactly.
But few of them probably who are very conscious about this altered sensation in the lower lip, because we have to give them figures, and sometimes we may say that in very, very few cases, the nerve damage could be permanent. Because some people ask you the statistics, what is the incidence, what is the percentage, whether I would fit into this group or the other group. So for that kind of patients, I think I said, if you are so concerned about it.
Yeah, now I'll answer your question.
Yeah.
One is, say, when Kishore told me, I decided that I would learn how to do an IVRO. That's why I got the sheep's mandible. And then, then I came to realize in my own mind, maybe I'm wrong, that there is no need for that. I have never done one intraoral. Okay, extraoral I have done. Intraoral I have never done an IVRO. And the other thing, what I would say in my own defense is, now I would have done more than close to 1,500 BSSO. And on very few occasions, I have had this problem of a long-term neuropraxia. 1 or 2 cases were there, but it did resolve after some time. So to my credit, because I do a very long-term follow-up of my patients, most of them, I have never had this problem per se. Another thing is, as I mentioned in the technique, the extra precaution or the modification of the technique that I do in order to cause less damage to the inferior alveolar nerve. So these days, many a times, and I've showed it to a lot of people who have been a witness for me doing BSSO, I have a sliver of bone over the inferior alveolar nerve. The inferior alveolar nerve is not seen at all. So there is absolutely no problem that I foresee. But it is a cause for concern, as you have just described. But I don't do IVRO.
Yeah, just a theoretical question. I'm sure even if you don't perform, you are a master of orthognathic surgery. There is a question now from the audience. How does airway issues differ in IVRO from BSSRO, when in both the amount of mandibular setback is same? Do we have an answer for that?
No, I don't have an answer. So that's what I'm saying. When this airway thing bothered me a lot when he said most of the patients in United States are complaining of OSA. So first I thought I'll go and verify whether literature supports that. No, literature doesn't support that there is any evidence to say mandibular setback, whether you do BSSO or whether you do IVRO, has any hardcore evidence to suggest they have gone in for OSA. That is number one. Number two, there is no literature evidence to suggest that if you do IVRO, except one article, Ghali's article, okay. Otherwise, there is no consensus in most of the literature that I said that IVRO can cause less OSA. And if it does, I don't know why they say so. I have no answers. Somebody like, I think Pramod or maybe Abhay can answer this. I have no
I'll
answer
ask,
for that question.
yeah, I'll ask Abhay about this, but let me just, if with your permission, add a point. Even in IVRO, the proximal segment is going to rest on the lateral aspect of the ramus. And even in the sagittal split ramus osteotomy with the Hunset modification, it is going to be a short split, and we are not currently doing more than 7 millimeters of setback. So in both the procedures, in either of the procedures, I don't think OSA or reduction in the airway space is a big problem, because
absolutely,
if it is such a big setback, we are going to do Bimax anyway. We are going to compensate with maxillary advancement. What do you say, Abhay?
Am I audible?
Yeah, yeah.
Yeah, to speak about the airway issues, there was a meta-analysis published by Al Moresi. If you see the International Journal of Oral and Maxillofacial Surgery 2015 edition, September, he compared the use of bimaxillary surgeries versus single jaw. And since it's a systematic review of literature, I quote this article because he says, at any given instance, a bimaxillary surgery is much more versatile than a single jaw or a IVRO, because developing an obstructive sleep apnea, as Dr. Mustafa spoke in his presentation, is more dependent upon the preoperative factors what the patient is prone for in terms of OSA.
Hello. Can we proceed?
Dr. Vivek is unmuted.
Can we proceed? Okay.
Hello.
Are there any other questions?
I would like to ask you one question.
Okay.
Dr. Vivek, are you there?
Yes, yes.
Any comments on this, what I spoke about?
No, I fully agree with you. Even many youngsters are asking in the chat, when do you decide to do a Bimax? What would be the limit of setback now? Though Dr. Mustafa initially said you can do large setbacks, but I'm sure many youngsters would be reluctant to do that.
No, that is not what I'm advocating. So
yes.
What I'm advocating is what is desirable is around 6 millimeters, 6 to 7 millimeter.
Yeah.
More than that is not that what I would consider doing at this juncture.
Yeah.
Most of the cases I would do, for the reasons that I cited, would go in for a bi-jaw surgery. Okay.
Yes.
So that would eliminate all these problems that we are discussing. Yeah. And another point that I would want to add in terms of OSA is a bit overstated. You know, since MaxFac surgeons got involved in OSA, okay, they had started looking or observing it very closely. And it happens very often when we gather some information, we would always try to look everything in the prism of that thing what you are trying to find. So for every time there is this huge debate about OSA, and OSA comes in the way. But when you're doing a bi-jaw surgery, all these issues to a large extent gets negated.
Thank you, Mustafa, for that clarification. One question to you and one question to Abhay. One question to you, Mustafa, would be, what are the chances of bad splits by using these curved osteotomes? So that was a concern expressed by one of the audience.
Okay. See, one of the reasons why bad split can occur is where the mediolateral width of the mandible is very thin. Okay. Another scenario where you can encounter a bad split is if the superior inferior distance of the mandible is less, or a short mandible. These are areas when you use your osteotome quite forcefully, there is always a possibility of a bad split. Okay. In my entire career, I said I have done close to around 1,500 bilateral sagittal split osteotomies, and I have had 2 occasions where I have a bad split. And in both the occasions, it was a little bit of overzealousness from my side. Okay. being a little bit in a hurry. But by and large, if you apply the principles of how to do a BSSO osteotomy, it's unlikely to have a bad split. And when you do, when you use this curved osteotome, what you need to do is, it's very difficult for me to demonstrate on the screen. As you tap the osteotome, you should direct the osteotome a little laterally, and then it goes a little medially, because it doesn't go and hit the lateral cortex. Because if you hit the lateral cortex, and if the lateral cortex is very thin, there is a likelihood of a bad split. So how to avoid that is trying to be cautious. Okay, you have to gain some experience by observing people who are doing it. And if those who are interested to learn this technique of how to use the curved osteotome, they can either come to me, go to Abhay. Another person that I would recommend is Kannan, who does this. And I think it has been safe so far.
Okay. Dr. Mustafa, I got a couple of questions. Dr. Vivek, can I ask a couple of these questions here?
Yeah, just one last question.
Yeah,
Abhay,
sure,
then you can take over, Kotra.
Yeah, yeah.
Abhay, audience want to know, once you've chosen to do semi-rigid fixation for these BSSROs, would you use splint post-operatively? What are the protocols? Any elastics or any rigid TMF?
If there is a supra contact anywhere, then possibly you would use your elastics to get your planned occlusion. Number one. Splints is a matter of choice. When you do a multi-segmentation of the maxilla, when you do a 2-piece or a 3-piece, you would retain the splint there in position so that you are more stable in that particular area. When we say intermaxillary fixation, it does need not necessarily be a wires intermaxillary fixation. We would put the patient on guiding elastics so that our intercuspation is at its best.
Okay, over to you, Kotra. Thank you,
Yeah.
Abhay.
Yeah, Dr. Mustafa, the first question is, how do you manage the gap after doing a vertical elongation genioplasty?
Okay, that's a good question. So whenever I do a vertical or what you call as clockwise rotation of the chin, let us understand this as we go along the talk to understand what is clockwise and anti-clockwise. Anti-clockwise is towards the cephalic and clockwise is towards caudal. Okay, so let us keep it very simple. So if you want a downward rotation of the chin, then you have done a mandibular setback. So whatever bone that you get, I usually put it as an interpositional bone graft. If I require, I'll harvest additional graft and use an interpositional bone graft. Any gaps?
Yeah, sorry.
Yeah, any gaps, irrespective, which I'll come to it later. Any gaps, irrespective whether it is for genioplasty or LIFO1, if there is a gap, I would fill it with bone for additional stability.
Okay. The other question was about double chin, the appearance. In one of the reference articles which you mentioned, wherein after a mandibular setback of about 9.4 millimeter with a genioplasty osseous reduction, there was a significant thickness which was noted in the chin area. Now, would you say that it is better to keep the mandibular setback at 6 millimeters, and then you can be more definitive saying that double chin occurrence is not likely, or you go beyond 6 millimeters, you are likely to have a double chin?
No, say if I am going to do a setback of more than 7 millimeter, I would at the present juncture consider a bimax osteotomy.
A bimax osteotomy.
Yes,
okay.
Or a bi-jaw surgery. Okay,
and
I would not exceed the limit of more than 7 millimeters max. In case if I do a 7 millimeter, I'll compensate by doing an advancement genioplasty. As I mentioned earlier, it will restore whatever negative effects of the setback, and it will also restore the corpus length of the mandible that you have lost. So it is a good bargain, I feel.
Okay. Or do you also consider additionally doing a liposuction to compensate for the double chin formation?
I would not, because if you have not significantly reduced the corpus length of the mandible, then why should you do? If it happens subsequently, yes, but as a prophylactic measure, no.
As a prophylactic, not necessary.
Not
And the other one is whether there's a talk about.
But if there is a pre-existing one, yes.
Yeah. Okay. The other question was about obstructive sleep apnea. So there was a discussion on it as to if you do advance the maxillomandibular advancement by 10 millimeters, then also the genioplasty is going to open up the posterior airway space to a considerable extent.
Yes.
So would you say that there is an objective evidence that along with maxillomandibular advancement, that you need to do a advancement genioplasty simultaneously?
See, the genioplasty in this case has an aesthetic consideration and also a functional consideration, which needs to be decided with the degree of caution, okay, depending on the case. Now, if there is a maxillomandibular deficiency, I see no reason why you should not do a genioplasty. You can do a genioplasty, you know, because that will help in aesthetics as well as functionally.
Put Dr. Vivek back.
Yeah, Abhay.
Hello.
Yes, Abhay.
Am I audible?
Yeah, please tell me.
Yeah, in continuation with the nerve injuries, I just wanted to add a few points for the sake of the postgraduates. What we have started now, and as I and Mustafa sir very often operate together, we have started using the piezo, where we get a very fine cut. And preoperatively, as a primary workup, what we can do is get a CT or a CBCT of the mandible, where we are planning to do the bilateral sagittal split osteotomy, identify the amount of cancellous portion of the bone marrow, and then plan your osteotomy cuts. So you for sure you can understand that how much of cortical junction you have in the mandible versus the cancellous junction. And the other point is the paper produced by Johan Rennike, where he spoke about, it was a comment in one of the papers where he spoke about use of splitters and spreaders. Use of splitters and spreaders. The splitter is something which I was introduced to by Pramod when I saw him first do and use the spreader and the splitter simultaneously at the superior border of the vertical arm and at the inferior border, where he would do the osteotomy and use them both simultaneously, so that the inferior border would come on to the proximal segment. Another paper which was produced by Timothy Turvey, Complications in Orthognathic Surgery, a review of 1,000 cases, where he speaks about the reverse alphabet J for jolly, the J coming on to the proximal segment, which is an indication that you don't have, your split has gone as planned. So the take home message is, read your scans well, whether it's CBCT or a CT scan, get into your armamentarium, see whether the osteotome what you're using is a 5 mm or a 7 mm, a curved osteotome, and then plan your BSS. Thank you.
Thank you, Abhay.
Yeah, Dr. Mustafa, last question for you is about there is no mention which was made or comments were made regarding the size of the tongue and the hyperactivity of the tongue in case of a mandibular setback. Does it have any effect in the relapse? Because there are procedures suggested for tongue reduction also to prevent.
See, these are all some of the things which are overstated. Okay. Now, I keep this in mind, a large tongue having the possibility of a relapse. And I have seen that it has not contributed significantly in terms of relapse in many of my case series. I don't think so the tongue has in any ways contributed towards relapse, because tongue is a very, very adapting organ, and most of the time it adapts very well, except one case I had, which I thought about tongue reduction, where the patient had an anterior open bite, and she was not very cooperative in wearing those tongue restraining devices because she could not tolerate. In such rare instances, probably we can think about a tongue reduction procedure or any other adjunctive procedure that you may need. But in standard practice, I don't think so a large tongue contributes significantly towards relapse, though there are some evidence of literature, because in my own practice, I have not noticed it. Though I have seen people with macroglossia, but it has not altered my results in any ways.
Sir, can I come in for a minute?
Yeah, sure.
Can you enlighten the audience? There is a question which is repeatedly coming on condylar positioning. What is your experience in condylar positioning? What maneuvers would you entail to make sure that the condyle is sticking there in the glenoid fossa? And a small speech also on redo BSSO.
Okay. Let me address the first problem, that is condylar
positioning.
Yeah, positioning, because you want to prevent condylar sag. So one of the things that I do is I make sure that the vertical cut, where you have done the vertical cut and you do the setback, it is very flush. And I check the lower border contact, because if it is in proper contact, that is one of the indication where your condyle is in the right position. And when I do the fixation, one of the things I do is I put the plate there first, position the plate, and I fix the proximal area first, and then I use a curved artery and hold that plate where I put the screw, and try to push it posteriorly and superiorly, assuming, and keep a finger on the glenoid, supposed glenoid fossa area, to make sure that it is not taken in unusual position. These small little maneuvers have helped me considerably to make sure that there is no change in the condylar position. But I must admit it, in one case, I did have, in a case of mandibular advancement, where within 2 days, I noticed there is a change in the condylar position, and I had to go back again and refix it. But these small things like, and another thing that is very useful is how your assistant holds the reverse Langenback. The reverse Langenback will help you to put the proximal segment in the most ideal position. And including that plate which you have fixed primarily onto the proximal segment, you keep an artery forceps, push it posteriorly and superiorly. It is more likely to be not too much of force, because it may go and hit the disc. So just make sure it is quite passive. So you need people who understand what you're doing. And one of the advantages that I have are my fellows, because they are fine-tuned as to what to do and what not to do. So that is one great advantage I have, and I should thank AOMSI for that. So these are the two things that I would do. Coming to repeat BSSO, what I would consider as a good armamentarium to do repeat BSSO is the use of piezo, because your cuts could be fine, very precise, without having to lose much of the bone, because there is a lot of fibrous tissue there. And I would be very, very careful in using the osteotome. I hope, Abhay, you remember that girl from Mumbai whom I had see this, I did a repeat BSSO for a bad split. I had a bad split. Yeah. Can you hear me?
Yes, yes, very much, very much.
Okay. We had a bad split. I had a bad split primarily. I didn't proceed with the BSSO. I stopped, came out, waited for it to heal. After 1 year, we went back. Abhay was there with me. We used a piezo for her, and we did a repeat BSSO. So piezo is one good armamentarium that you can consider if you are going to do a repeat BSSO. But I must say, repeat BSSO is a difficult proposition if you compare it with a repeat LIFO-1 osteotomy.
Okay. And the second question, sir.
Hello.
And the second question.
Yeah.
Yeah. And the other thing is, there is a paper by Malcolm Harris. This is a question which is popping out in the Zoom window. So I thought we will just clear it off. There's a paper by Malcolm Harris where they use multiple osteotomes for splitting in bilateral sagittal split osteotomy. Since you have done thousands of these cases, What's your take when you use your osteotome? Would you still believe that you finish your medial osteotomy, come on to the intermediate and then do the vertical, or do the same proposition of placing a huge osteotome, the Obwe-Gezer's bibeveled osteotome, aim it towards the angle and then give a clockwise or an anti-clockwise turn, depending on which side you're doing.
Yeah. I don't know if I can show this mandible here, but I don't think so. Is it visible?
You can lift it up a little bit, please.
Yeah. Is it visible? One second. I'm taking some technical help.
With your permission, Mustafa, can I just show the audience one slide regarding condylar bearing segment?
Yeah, sure.
Praveen, can you please allow me to share my screen once?
Yes, sir. It's open, sir. You can just do that. Share screen and select that slide.
Okay, when you're doing that, can I just complete what Abhay has said?
Yeah, please go ahead.
Okay.
See,
one of the good ways of doing it is, as I mentioned earlier, put the osteotome superior inferiorly, and the inferior most extent of the vertical cut, you use what you call as a curved osteotome, which I mentioned earlier, and try opening it simultaneously. So what happens is, in the process, you will create a pathway through which you can work out and safely do it. So put an osteotome superior inferiorly, put the curved osteotome at the inferior portion of the vertical cut, and open it like how we are opening a book or the cover page of the book.
Sir, is there a video which you can show us for this particular procedure?
I'm sorry, but I had recorded this video during the last workshop that we had just 2 months ago, but I came to realize 2 days ago the copy of that is missing. I don't know what has happened, but we did.
Can you see the slide on your screen?
Not yet, sir. You need to share the content.
Yeah.
Share screen, sir. Just click share screen button.
Okay, 1 minute.
And select that PPT.
Okay.
Yes, sir. Now we can see.
Yeah. This is a wonderful article written by Professor Reddy on condylar repositioning devices for orthognathic surgery. So the youngsters can read this article, and the illustration is self-explanatory. So just gently push the proximal segment into the fossa and also support the lower border. And I'm sure there are many ways of doing it, but if you can be little careful about the continuity in the lower border area, you will be safe. And another one, if you want to be very sure about what you're doing, then fix a plate between the ascending ramus and the zygomatic buttress area before you start your split. Then remove the plate, complete the split. When you want to fix the osteotomy, refix this plate from the zygomatic buttress to the ascending ramus, and then fix your mandibular osteotomy site. So these are the two simple mechanisms I think one can adapt to make sure that the condyle is properly seated in gland and fossa. Thank you.
Yes, Vivek, I think, Vivek, that you brought in a very good point. I had seen this slide before. Maybe a little arrogance on my side, because this is what a beginners should understand and probably inculcate, because there are less chances of you going wrong, because condylar sag is a huge problem. So this is something I would recommend to beginners who want to do BSSO and want to do it perfectly. One should follow what Reddy, Vivek has just proposed. That's a very good idea. So before we proceed, there are some questions which have come directly to me asking about angle osteectomy. Okay, as we go further, I will bring in a slide and demonstrate how it has been done. But in the previous case I showed, it is very, very easy to do that, because since you have done the BSSO, you can pull the proximal segment a little forward. You will have adequate access to the posterior lower border of the ramus. And you can mark with a pencil. No, not that. You can mark with a pencil. No need. You can mark with a pencil and do it very easily. But just in case, if you have to do the angle ostectomy without doing a BSSO, then it is a little difficult task. But if you have a saw with you, it is very easy. It is rather very easy. But with the combined with the BSSO, even a beginner can do it. Only thing is, make sure you mark, you assess, because both side ramus length may not be proportional. So you need a little bit of planning. So can we proceed further?
Mustafa sir.
Yeah.
Mustafa sir.
Yeah.
Pramod, can I ask a comment from Pramod? Pramod, can you hear me, Pramod?
I can.
Yeah, Pramod, can you just enumerate on the use of spreaders and splitters? Because I've seen you very often do that. It's a fantastic technique, what I've learned from you. So I just wanted your take on this, Pramod. You use the priors at the inferior border and the Smith spreader at the superior. So how
so
exactly
these are
is that?
regular instruments that are, yeah. So you can use two. You can first step is to make sure that
you're frozen, Pramod.
Cut goes through the cortex all throughout the BS. Is that better? Can you see me? Can you hear me?
You're too loud. Yeah. You're frozen now.
Can you hear me?
Yeah.
So the first step is the surgical procedure itself, that you have to ensure that your cut is through the cortex throughout the line of the BSSO. Okay. And the second part is you could use two instruments. One is your regular Smith spreader on the top, and at the lower border, you could use a Obvious spreader. It's an instrument that is available with most of the companies like Stryker and Careless Martin. So you apply forces at two places. One is on the superior border and at the lower border. So that is even force. If you apply force only at your superior border, and if your cortical cut is not complete, then there is a higher chance of a bad split. Okay. That's the answer to your question. Now, Mustafa sir, can I ask you few points for clarification,
please? Quickly, because we are still stuck with the first discussion. We have seven things to discuss.
Yeah. So the first point is the IVRO is primarily for setback, correct?
Yeah.
It is,
don't ask me questions in IVRO. I don't do IVRO.
No. I agree. But it's an understanding. For the people, right, who are listening. IVRO is primarily for a setback. It's not routinely done for. So the quantum of setback that is done with an IVRO and BSSO is almost similar. You don't do large setbacks with IVRO, right?
Yes.
So we would say that the airway changes that should happen with IVRO and BSSO should be similar, if any.
Yes.
Yeah. So the literature very categorically states from multiple studies that even though there may be changes in the airway dimensions following a setback, but that does not correlate with actual obstructive sleep apnea.
That's what I precisely. That's what I precisely said. That airway space may change, but it need not manifest in OSA.
Yes. Now another question is, you mentioned about gonial angle change. Now, what does the literature say about gonial angle change with BSSO and with IVRO?
No, some says it is better in IVRO. I quoted that. And
what do you mean by better? What do you mean by better? It reduces or increases?
It reduces, obviously, which is which see, the gonial angle in a mandibular prognathism is likely to be more obtuse. But if it's a steep mandibular plane, it is going to be more obtuse. Okay, and it will become it's likely to be more acute as you set back the mandible. And what they say in Ghali's article, it is better in IVRO, but many other articles say there is absolutely no difference.
So does your assessment of the shape of the mandible have any importance in that? Whether the mandible is V-shaped or U-shaped, does that have any implication in that while sitting?
When you say U-shape or V-shape, where do you mean the U-shape and V-shape?
The mandibular shape per se, the body of the mandible, body angle.
Yeah. What can play a significant role is the mandibular plane angle, nothing else. If the mandibular plane angle is very steep, it will limit your your changes unless and until you do the you do a vertical reduction anteriorly. So if you are going to do a anti-clockwise rotation of the mandible, then probably things
No,
would
I'm
be
not
better.
talking about. I'm not talking about rotation, sir. Somebody just texted me privately. It's the correct terminology is ramus divergence. So we know that if there is a increased ramus divergence and you're setting the mandible back, then the proximal segments would flare out, right? Which can affect the gonial angle shape, which we need to keep in mind. Is just a point that I wanted to bring out. Now, there's one more point that I want to make regarding the tongue size. Somebody had mentioned about tongue size. Now, it is common practice with our orthodontists that if the AP discrepancy is large, or if it is a patient with an anterior open wide, they usually have hyperactive tongue, which also could be a larger tongue. But she manages the orthodontic treatment with giving a tongue crib. She does not put brackets on. She puts the patient on a trunk crib for 3 to 6 months, and it reduces the size of the tongue and reduces the hyperactivity of the tongue. So that might be a good practice to tell your orthodontist about. Just a point.
That point I already made, because most of these patients, especially when they have open bite, what we start first is by giving a tongue clip.
Okay, Mustafa, I think we should move on, because you have a very.
So I have a small request. So before we proceed further, say now we have 7 things to discuss. So we have in 1 hour discussed. So we need to
move on.
Catch up. Yeah, move on. So say what I would recommend is we will not dwell much into the technicalities, because we are not talking about technical things. What we are talking about is concepts. Okay, not about techniques. So we will limit our discussion to the techniques and dwell more on the concept itself. Okay, so otherwise we won't. This will be a never-ending thing. So how do I go to the next slide? Okay. Now coming to maxillary procedures. Okay, I have now spoken about doing maxillary advancement, so I would not dwell into that. What are the other things that is possible? You can do a maxillary inferior reposition. Okay, you can do a maxillary setback. You can do a maxillary superior repositioning. So if you want to do all these things, what would be the most versatile thing to do? And this is what I would suggest, or I would recommend rather, to do a 3rd molar osteotomy. So there are some distinctive advantages. Let me come to these advantages. They're anatomically less hazardous, because you are not entering into any of those dangerous space, allows greater mobility of the segments, and it permits a large vascular pedicle. So let me explain to you what it means by a large vascular pedicle. Because when you do a pterygomaxillary disjunction, where the pterygoid separates from the maxilla, it's a point contact. Okay, so you are taking the maxilla either forward most of the time. If you're taking it superiorly, again, you may have to remove bone there. But the pedicle is quite small there. If you're doing an advancement, you have a larger vascular pedicle if you're doing a 3rd molar osteotomy. Now, these are some examples. So let's quickly go through it. Some examples when of a case which we have done a superior or impaction of the maxilla. That's her. That is the profile view. That is the final occlusion. This is another case where we have done the setback of the maxilla, okay, where posterior movement of the maxilla, that is the profile view, and that is the occlusion, okay. Now, here is this case, a very interesting case, not a case in terms of technique, which is interesting. This is a case of maxillary hyperplasia and mandibular excess, or maxillary deficiency or mandibular excess. That's him. That is the occlusion, and the patient is undergone pre-operative orthodontics. The orthodontics, they have planned it very well. That's the pre-operative radiographs. This is the osteotomy cut, as you can see. To have done that extension, it's a high modified Lefort 1 osteotomy if you want to address the problem of paranasal hollowing. So that is not what I want to discuss. Okay. I discharged the patient on the fourth postoperative day. I discharged the patient, and the patient comes on the 12th postoperative day with something like this, with a big palatal ulcer. The gingiva were denuded there, bone exposed palatally as well as buccally. I tried to elicit a little bit of bleeding at the margin of the gingiva. Not a very positive response. I tried to do a little bit of bone shaving, but the response was not positive. It wasn't bleeding. So it was a very, very alarming situation. So what this is, I would say, my COVID moment, one of my COVID moments. Like Kishore, even I had plenty of COVID moments in my life, professionally and personally. So this is one of my professional COVID moments. Okay. So I came to a conclusion of patient going in for an avascular necrosis. So I debrided the patient. These are, I don't need to dwell into the local causes and the systemic causes, from cigarette smoking to the use of vasoconstrictors and high dose steroids and things like that, and some of the local conditions which could be craniofacial dysplasia, surgery related. For example, if you transect the descendine palatine artery, I've seen many of them doing it intentionally. Of course, there are multiple sources of supply, as this slide suggests. I would quickly go through it. Okay, blood flow of the maxilla is reduced 50% in every case in the immediate post-op, in the aftermath. Okay, but it is the collateral microvasculature that we need to depend on. The pedicle can withstand, and that is, I'm talking in terms of maxilla, a stretching of greater than 10 millimeter. But as a standard practice, whenever I down fracture the maxilla, I look for the descendine palatine artery, whether it is intact. I'm not one of those who will transect it or ligate it or do any sorts of things. So another thing that I would like to bring in here is that there are other collateral supplies. So in this particular case, these are some things describing about the blood supply to the maxilla. I won't dwell into that much. Okay. One other thing is your flap design. Some of them recommend that your buccal incision should not be all along the length of the maxilla. Keep it short, end it near first molar. That is what I precisely do in most of the cases. Am I going forward? Okay. So this is on the 13th post-operative day, and the patient came. I immediately took the patient into the theater and debrided it completely. So when I thoroughly debrided, I could get some response. It started bleeding from the big palatal ulcer. Of course, Abhay was there as a great support for me in this case. I must admit that. Okay, this is on the next day. Okay, and then we made this decision to subject him. Okay, we can discuss this a little bit more when we discuss, when the discussion phase comes. So this is on the 14th post-operative day. Okay, this is on the 15th post-operative day after the patient underwent the first HBO cycle. We decided that we will subject this patient to hyperbaric oxygen therapy. So this is on the second HBO cycle. You can see progressively it is improving. On the third day, on the fourth day, on the fifth, on the sixth, on the seventh day. See, there is a progressive improvement, though it was a COVID moment for me. I felt quite encouraged. I was keeping a day-to-day track of what's happening to this patient because we don't have HBO therapy in Bangalore. I had to send this patient to Bangalore, and those who are interested, I can furnish the details of the place where I sent. There are other places as well. And this is on the 10th day. On the 15th day, can you see that the ulcer has completely healed? Okay. Even I went to that place. Of course, one of my fellow, you can see they're sitting on the extreme right is the patient. Then it is me, and next to me is my fellow who stayed with the patient. I mean, who accompanied the patient and took him to the HBO therapy every day. And I also went in and I wanted to experience and see physically how the patient is doing. That's him 2 months later. And that is what we got after 2 months. That's his profile, postoperative and Ceph. So what is surgery? It is the management of surgical complication. The rest is all butchery. So we go for discussion 2. It is open for discussion. Abhay, I start with you.
Mustafa sir, are you able to hear me?
Let Abhay start the discussion.
Mustafa sir, are you able to hear me?
Yeah, I can hear you.
Yeah. Initially, in your second set of presentations, you spoke about Lefort osteotomy and your variations.
Okay.
One doubt I have in mind is, do you approach the third molar for your third molar or the Trimble's technique with the separate incision, or do you tunnel down with your buccal incision? And if so...
Okay, I have a video on how to do a Lefort 1 osteotomy, a short video, which I will play it later. Okay. So it will, I do put a small incision. You would see that in the video very clearly, a very, very small incision. And I don't think so that incision in any way could have contributed to the problem that we had. So we will discuss what could be have the likely clause for this discussion. Others can pitch in. Let us quickly finish. Any other questions? Do you have any other questions?
Any other grave complications you have come across in your private practice of 1,000 cases?
Is this Abhay?
Yeah. Are you able to hear me?
Yeah. I'm able to hear you. Okay. Yes, I did have, but I need some time to go back to the extra slides. Extra slide. The extra. 1 second. Let me. I did have another greater COVID moment in my life.
Okay.
Let me just.
When you're doing that, I think our co-hosts can give you some questions. Dr. Kotrashetti.
Yeah, sure.
Please come in, Dr. Kotrashetti.
Yeah. There are two questions which are asked by the on the tweet group. That one is whether do you use pentoxifylline in the post-operative period when you feel that the soft tissue is looking more dusky?
Yeah. Now in this patient, that's what I didn't go to the entire management. Okay, we did use pentoxifylline for this patient. Okay, we also used vitamin supplements. Okay, Abhay, can you pitch in and give him the complete details of the medication that we did for this patient?
Kotra sir, to be clear with this, initially when the patient presented to the trauma, as Dr. Mustafa spoke about, we recognized this entity and we started the patient immediately on TAP pentoxifylline, number 1. We also started the patient on Evion, number 2, and daily debridement was anywhere happening anyways. And the third or the fourth component was use of Placentrix gel, which is marketed by Albert and Davis in Bangalore and Karnataka. It's Placentrix gel is something what we use extensively when patients present to us. From my knowledge in Manipal when we used to get a lot of cases of maggots. Once the maggots used to be drained out, what we do is we would see bare white bone. For that granulation tissue to form, we used to use the Placentrix gel. I'm sure you have used it too. So we got this concept of using the Placentrix gel there so that we could make holes there and then apply the gel. So from the medication point of view, we put in pentoxifylline, vitamins, Placentrix, and injection clindamycin.
Okay. Now, can I, you asked me a question whether I had a grave complication. This
No,
is
okay. Dr. Kotra has something to say.
Other one more question, which is,
Yeah, what is the other question?
Other question was whether would you prefer to do a twist down or twist technique for the disjunction so that the complications of pterygomaxillary disjunction can be reduced?
You mean with the osteotome, you go straight
that's
down?
exactly.
Yeah.
Yes.
No, that is a useful technique. I am not denying that. Especially when, see, why I am proposing or talking about the third molar osteotomy, it has much more versatility. Now, if you want to do a superior repositioning, that's the best part because you can do a parallel impaction with a third molar osteotomy. If you don't, because it permits you to remove that bone there and do a parallel impaction. If you do a pterygomaxillary disjunction, it becomes a little difficult for you to remove that bone there. And I have once encountered when you have done a pterygomaxillary disjunction and impacted the maxilla has come forward. Then I had to go back and then redo the whole case. Thankfully, that patient happened to be my close relative, so they spared me. Now, coming back to, that's a good technique. I agree with you. But I'm not saying that the other techniques or pterygomaxillary disjunction is not good or anything like that. What I'm saying is that third molar osteotomy is a little more versatile because it will permit all kinds of movement: setback, advancement, superior impaction, and downgrafting. So it has a little more versatility compared to other. Now, the other thing which Abhay asked about a grave complication, this is one of the biggest complications I had in my life. So let me narrate it to my viewers, not to scare them away, but I have learned something from this. This is a patient with, again, VME, and we did Lefort 1, AMO, all sorts. I won't go into the nature of the surgery, but I will tell you what happened. It was one day prior to Eid. Next day was Eid. The previous day I did the surgery. Next day, my fellow called and told me, this happened around 5 years ago, that, sir, the patient is febrile. So the patient was seen by a physician. The physician came and checked examined the chest. There was nothing suggesting that there could be some chest complication or anything like that. That's on the first, that's on the next day, of what you call the second POD. On the third POD, because it was done in an institution, they will always treat these orthognathic patients. They will keep it in the ICU and shift the next day. They take extreme precautions. So since it was a Sunday, they didn't shift the patient back to the ward. On Monday morning, my fellow went, everything was fine. Patient was afebrile, and the patient was shifted to the ward. 1 hour after shifting to the ward, can you all hear me?
Yes,
Hello?
yes, we can.
Yeah.
Yes,
1 hour after the patient was shifted to the ward, he was advised to take orally. So they got the bystanders got him a Musambi juice. So he drank the Musambi juice. The moment he drank the Musambi juice, he choked. The sister was there. She noticed it because we had an exclusive ward for our department. And the patient was immediately shifted to the ICU, which is 1 floor below, and intubated. Okay. And once the patient was intubated, of course, there was a brief period of drop in the saturation. The saturation picked up. Patient was stable and everything. I went in immediately. Within 15 minutes, I reached there, the hospital. Everything seemed to be under control. Within an hour's time, not an hour, after 2 hours, there was a progressive drop in all the parameters.
I'll put up the questions.
And all the parameters, okay, the saturation was dropping. They were treating the saturation. The heart rate was coming down. the BP was falling. There was somebody from the anesthesia side who was handling the case. There was no much role from my side to do anything except sit and hope for a good outcome. And at 12 in the midnight, we lost the patient. And it was very difficult at that point of time to tell the patient's father and mother as to what has happened. But nevertheless, we had no choice but to tell them. So I called them, and I had to, as a surgeon, you are the leader, and you have to announce this bad news. You can't ask somebody else to do that. So I had this very difficult task of announcing a death of their 19-year-old son. But that is not where the ordeal ended. Okay, it came in the newspapers subsequently that a patient for dental surgery at the Yenapoya Medical College died due to medical negligence shown by the doctors, and he was admitted there for dental surgery. So because this patient was earlier seen in the periphery by a local doctor, and the local doctor was also under severe pressure. And I must say this, it is certainly not a good thing to say, but it also, because this is what the local doctor from that peripheral area told me, they came, barged into my clinic, and they said, they came and said, because she was a lady doctor, and around a mob of people entered into her clinic, and yeah, sorry. They said, why do you have to send it to a Muslim hospital? There are other hospitals where you could have sent this patient. And there were some fringe groups who
Mustafa, let me just intervene. Very sad and unfortunate news that it happened to one of your patients. It could happen to any surgeon. All the youngsters have to realize that Lefort one osteotomy, though it looks very simple, it is a very risky procedure. They have to take care of all the pre-op investigations, and proper preparedness has to be there. You have to make sure that basal hemoglobin and RBC count are fine. You have to group and save. You have to tell the patient about the necessity for blood transfusion. You have to be extremely careful with these complications. Of course, the best bet is to prevent these complications by properly knowing the anatomy, all the vascular supply to the maxilla, and what all things can breed during surgery, importance of hypotensive anesthesia, everything. But in spite of taking all these precautions, we should be highly vigilant during immediate post-operative period regarding the complication of hemorrhage, which is actually not very uncommon. I have heard these things happening in the best of the units, and many
now can I continue?
Yeah, please. Okay. I just thought
in this patient, the surgery went on very well. In post-operative period, there was no any untoward events, because the patient didn't have any episodes of bleeding or anything. during the surgery or in the aftermath of the surgery. Okay. Next day also, when they checked the patient, there was nothing to suggest that the patient had some aspiration or anything like that. Okay. But when the patient was progressively deteriorating, and when the chest X-ray was done, there was a huge patch there, which is suggesting of an aspiration. Now, the question is when the aspiration would have occurred, whether it has occurred during intraoperative period or whether it has occurred during the post-operative period. I am not certain, because next day when they checked that, they didn't do an X-ray at that point of time.
Zoom chat
Abhay, can you mute? Okay. So we are not sure about that, but this is not a surgical complication. Okay, this is purely a medical complication. But let me explain to you what has happened, so it will get you a sense of the issue. So at one aspect is there was social pressure, as I was trying finding it hard to explain it. Okay, so one of the things that I wanted to do is to call a medical review committee, because to know exactly where we would have gone wrong, because that's what we should do in a situation like this in order to prevent future incidents like this, you know. So we were not able to pinpoint at what could have precisely gone wrong or where it could have gone wrong and things like that. They could not come to any conclusion that what could have potentially caused this problem, or if there is an evidence of aspiration, when it happened. He's a young guy. Even if you have aspirated, we should have been able to save him, you know, because aspiration, it takes some time for pneumonia to set in. It can't be so acute all of a sudden. And a patient who's gone into the ward, hale and healthy, just drank water, choked. So where things have gone wrong, I am not able to precisely pinpoint, despite my best efforts to learn that. Of course, this is the social problem. But I'll tell you the other problem what happened in the hospital. The anesthetists were not willing, subsequently the anesthetists were not willing to take up any orthognathic case. There was one case admitted. For 15 days, they did all the possible thing of doing a lung function test, of doing a preoperative bronchoscopy. This is called as overkill, which is not required. If you follow standard operating principles or standard operating procedures, which is otherwise called as SOP, which is relevant for all patients, to a large extent, we can avoid complications. But sometimes, despite our best efforts, so this is one of my what do you call the bad phase that I went through during this case. And then this case went in for a commission. Okay, the commission conducted an inquiry, and this is what they had to give the opinion. There are no lapses in the anesthesia management and the post-operative management from day one. The patient was hemodynamically stable and tolerated oral fluids well. After 36 hours approximately on fruit juice ingestion, he developed sudden breathlessness and later followed by fluffy shadow on the chest X-ray in the right, middle, and lower lobes, suggesting consolidation, a picture of aspiration pneumonia followed by ARDS. Okay. Then the post-operative mortality after facial-maxillary surgery is a very rare event, particularly in ASA1 patient without comorbid condition. But the onset of respiratory complication like laryngospasm, aspiration, and its sequelae, an unfortunate rare event which can still happen in a fully awake patient after oral surgery. Likely cause of this patient is ARDS due to aspiration, in spite of all corrective measures taken in terms of ventilation, fluids, antibiotics, ionotropes, and other drug supports. Okay, so that is what I had to go through. Of course, if one had to ask me what is the lesson learned, and the biggest lesson I learned is when the chips are down, even your good friends will disown you. That is one of the lessons I learned from this case. But when now what I said is in hindsight, okay? But when I think about it retrospectively, today as things stand, I have some idea about where things has gone wrong, but I would not explain this in a public forum like this. But I am, in my mind, I'm certain where things could have potentially gone wrong. Okay, so we move on to the discussion.
Mustafa sir, can I intervene?
Yeah, sure.
There are a few questions from the YouTube group as well.
Okay.
One question was, how many cycles of HBO therapy was given for the case of avascular necrosis?
Yeah. Okay. The first cycle was given for around 12 cycles. Okay. Continuous 12 cycles. Can you hear me?
Yes, yes, very much.
Yeah. Yeah. Then there was a gap of 5 days. Okay.
Okay.
And then they gave another 6 cycles.
Okay.
And they waited for another 10 days. Okay. And they gave in the end another 4 cycles. That 4 cycles were more of a precautionary thing, you know. But what is important is the first 12 cycles. And that is usually decided by the one who is in charge of the HBO therapy, not decided by me.
Right. And we have one question from Dr. Varghese Mani sir, asking us, how sure are we that the HBO therapy has helped us in cessating the avascular necrosis? Or
Well,
whether the...
now, see, that is a big risk you have to take. One can say probably constant wound debriding and thing could have solved the process. But here, we have been able to restore the entire maxillary segment. What we have effectively done is hastened the process of healing, and there is enough literature which suggests the impact of HBO in the process of healing, because basically what it does is it improves the oxygen tension and tissue perfusion, so thereby enhancing the process of healing. Now, one can argue probably it would have healed without subjecting the patient to an HBO therapy. That would be the risk that I will have to take. Under those circumstances, this is what I thought best, and the decision I took is successful, and success speaks volumes. That's what I would say. But I don't know. It depends what another surgeon would have done in my place or in our place, because you were also part of this case when the complications set in. And I would add another point. So in a situation like this, it is always better to have another surgeon by your side to make proper decisions.
And one final question from the YouTube group asking, this question is to both Dr. Vivek, Dr. Kotrashetti and Dr. Mustafa, whether there is a role of vasodilators in avascular necrosis. What I mean to say is any prostacyclin derivatives, does it have a role?
I think we did give a vasodilator in this case in the post-op when we were handling this patient, didn't we? I think so. We did. The first 2 days.
Okay. Vivek sir, anything on that?
Abhay, I must say, I fully agree with Dr. Mustafa. In the initial days of my practice, when we were doing a lot of reconstruction procedures with non-vascular free bone grafts, we had to send few patients to HBO therapy in Air Force Academy, Dindigal in Hyderabad. And though we don't have randomized control trials to prove whether it was genuinely the effect of HBO therapy, majority of the patients did very well after say 10 or 20 sessions of HBO therapy. Even now, not very frequently, but in our unit, whenever we do non-vascular bone grafts, if there are any post-operative clinical features which are showing the signs of infection at the site of interface of the graft and native bone, we do refer our cases, and they do very well. We can't answer if somebody says, well, you should have waited and allowed the patient to recover on his own. We can't do that because most of these patients have a lot of faith in us, and they underwent a major procedure. We can't take that risk. So definitely, I think it is justified to send these patients for HBO therapy, but I don't have any experience regarding role of vasodilators in the management of this kind of complications.
Yeah.
Maybe
To add to Dr. Mustafa and Dr. Vivek, possibly when we speak about HBO therapy, literature has it where HBO therapy, the amount of oxygen delivered is 100% at 3 atmospheric pressure. That means the patient is taking in possibly 6 ml per deciliter, as against the normal oxygen what we breathe at a rate of 0.3 ml per deciliter. So HBO therapy, a take-home message would be an ancillary measure if we could summarize it to say that. Anything, Dr. Vivek?
Yeah, I fully agree with you.
Yeah.
Only thing is the facility is not freely available.
Yes.
Nowadays it is coming up in commercial setup, but earlier it was available only in Navy and Air Force setup. But we are in Hyderabad, and fortunately we have a center where they don't charge anything to the patient. They just charge for the oxygen, which is just 150 rupees per session. So we are fortunate to have that facility in Hyderabad. But of late, we have sent our patients to some commercial centers also.
Okay, thank you so much. Thank you.
To summarize this, what I would say is, see, when you're confronted with a situation like this, you don't have much of a choice. So whatever supportive measures that you can give, you should give it to the patient. Okay. The other thing is allow it to deteriorate. So that you can't do. So HBO therapy, pentoxifylline, local debridement measures, even the, I normally don't get that name, what we constantly apply. Abhay, what is that?
Placentrix gel, sir.
Placentrix gel. These are all supportive measures which could save the day for you. It has saved us. I'm not saying that this emphatically, but we don't have evidence for any of these things. Okay?
Yeah, I think Mustafa and Abhay, we need to move on because ours is a very lengthy talk, and we don't want people to become impatient.
Okay. Now coming to the next thing, mandibular autorotation. So it is a vertical impaction of the maxilla, often giving rise to counterclockwise vertical movements of the mandible without actually surgery of the mandible. So this results in greater chin projection, a reduction in the lower anterior facial height, and deepening of the bite. Okay. There are a lot of literature as to where the center of rotation is. You can go through this article. It's a very good article defining where are the various point of rotation through which the condyle rotates. Okay. The magnitude of maxillary impaction was highly correlated to the horizontal displacement of the chin. It is 1:1. So for a surgical maxillary impaction of around 5.4 millimeter at the ANS and 3.7 millimeter at the PNS point and 5.4 millimeter at the occlusal point to the first molar, the chin position, that is the POG, moves upward by around 4.8 millimeters. So you can take this article as a baseline guidance. It may not all the time happen, but this is the baseline guidance. Okay, but to understand the phenomenon of autorotation for the benefit of the students, here is a case. Okay, this patient came with a complaint of mandibular prognathism. Okay, and what is her complaint? Her primary complaint was, many a times we need to interpret what their complaint is. What she said is she looks aged. Whenever there is a mandibular prognathism, you ask most of the patients, they will tell you this, but you should know the art of eliciting it. When they come to you, they'll say, oh man, so what if you're, I can ask the question which Abhay asks more often. You can ask that to the patient. So what? Okay, if your mandibular is prognathic, so what? So the same thing here, she complained that her man, so I asked her, why are you so upset? She said, it makes, I feel I look old, you know. So this is her, and that is her X-ray, okay. We analyzed the X-ray and we found out, I involved an orthodontist and they said, sir, the mandible appears normal, sir. Okay. Whether the maxilla is hypoplastic or deficient, they said, no, sir, the maxilla also is normal. And then we went on to do this faceport transfer. And in the faceport transfer, we found out she had lost her, I forgot to mention the history. This patient had a history of a full mouth rehabilitation. So in the process of that full mouth rehabilitation, the prosthodontist or whoever has done it, I don't think so it was done by a prosthodontist, they have compromised the vertical height of the patient. Okay. So what you can see in the second picture is the amount of loss of vertical height in their attempt to do a total rehabilitation. So what we decided is to do a Lefort 1 and downgraft the maxilla. So when we did this case, so I will add this point, whenever I downgraft a patients like this, you have to do interpositional bone grafting because that will add to the stability of the maxilla that you have downgrafted. So that's her in the postoperative period. Look at it. We have not done any surgery for the mandible. So what has happened is because of loss of the vertical height, the mandible has auto-rotated and come forward. So in the post-op phase, you can see that the mandible has taken an adequate position. So what has happened is the mandible has de-auto-rotated. Now, since you have restored the vertical facial height, the mandible has come into a normal position. You would see this in edentulous patient, their mandible comes forward because of the loss of vertical facial height. So this is a case to demonstrate the phenomenon of auto-rotation. That's it. That is her pre and post-operative X-ray. All that we have done is downgrafted the maxilla. Okay, now coming to rotation of the maxillomandibular complex. Okay, so if you want to increase the convexity of a profile, or if the patient has a concave profile, you can do a maxillomandibular rotation. Okay, and if the patient is requiring a less convex profile, okay, or mean to say if the profile is convex and you want to make it concave, then you do a counterclockwise rotation. So some of the things that you need to remember here is landmarks closer to the center of rotation will move comparatively less as compared to structures farther away from it. So here is it. Let me just explain because this is something a lot of people find it a little difficult to comprehend. What is in the blue is normal position. Okay. What is in the blue is normal position. If your point of rotation is at the ANS, okay, yeah, ANS, then you see how the what is far away from that point moves. If the point is at the center, that is, where is it? Okay, if the point is at the center, that may be somewhere in the molar region, then how the points move. What will happen is the anterior segment will come down, the posterior segment will go up. But if your point of rotation is the incisal point, this is in yellow, you would see that in yellow. Okay, so you have 3 points where it can move if you want to do a clockwise rotation. The point being ANS, the incisal point, or if the point is at the center. So this is a patient who had anterior open bite with maxillary retrusion, mandibular excess, and we did a clockwise rotation of the maxilla, mandibular setback, and genioplasty. So in this case, when we did the genioplasty moved in an anti-clockwise direction. That's her. That's the final occlusion. You can see that in the immediate aftermath, there was some amount of open bite, this patient was subjected to a tongue crib, and with settling elastics, we could manage it. And that's the outcome. Okay. Which video? Yeah. Now, let me show a video, a small video of how the clockwise rotation can happen. Look at that video very carefully. It's a very interesting video made by my orthodontist. Her name is Dr. Shreyas Tiwari. Shreyasi Tiwari, sorry. And I have other orthodontists too. Look at the video carefully. This is a normal position. Now, not normal, the existing position. That's the existing position of the mandible.
Mustafa sir,
yeah.
Can you share the video first?
Videos, you can't see the video?
No.
Okay. I'm sorry. I think it has not come into the frame.
Yeah, you need to share the content.
Share, yeah, share it. Can you see it now? No, go from the beginning.
No, you need to stop sharing what you're sharing right now and open that.
Yeah, okay. Now is it clear?
We can't see it.
Now? Yeah, okay. From the beginning, we'll play it. I'm sorry. Okay, that's the video. It's going to start now.
Yes.
That's the maxilla in the existing position, ANS, PNS. Mandible in the existing position, that's a pre-op position. That was the final position, and that is what we achieved in the patient since we did a maxillomandibular clockwise rotation. Pre-operative and post-operative. Now you see the superimposition of that. Okay, now let's get back to the original. So I think that gave you all a brief idea about the concept of maxillomandibular rotation in the clockwise direction. Can you all see the slide, counterclockwise rotation? Yes? I want the yeah.
Yes.
So this is the counterclockwise rotation. Here again, the blue ones. Okay. Get the cursor. Okay. The blue denotes the normal position. Okay. Now, when the center of rotation is at the center of that plane that is there, okay, Okay. So you will have the anterior segment going up and the posterior segment coming down. Okay. If the center of rotation is the ANS, or is seen in the red one, okay, you would see the anterior segment remaining stationary there and the posterior segment coming significantly inferior. And the yellow is the point of rotation, is the incisal point. Then you see how the rotation happens. Okay, so these are the three kinds of rotation in an anti-clockwise direction, just opposite of what I mentioned earlier. So let me explain a case where she had a problem basically with the reduction in the posterior facial height. So we wanted that to gain additional length. So we decided to do a counterclockwise rotation for this patient. So that's her. And here, what we did with the chin is we did the chin clockwise. Whereas in the previous case, we did an anti-clockwise rotation of the chin. Here, we did a clockwise rotation of the chin because we wanted increased lower facial height. So that's the outcome. And she's still undergoing orthodontics. Look at the X-ray. Okay, now we can have the third discussion quickly. About three things here. One is the concept of auto rotation. Number two, clockwise rotation, anti-clockwise rotation.
One question, Dr. Mustafa, is about when you do the counterclockwise rotation, do you use bone grafts in the posterior maxilla? And second one is when the muscle itself is lengthened, that is the muscles of mastication, is the posterior lengthening stable, or does it preclude to condylar resorption or secondary internal derangement related problems?
Yeah. See, I have no huge series of doing a counterclockwise rotation, but I have a huge series of doing a clockwise rotation. Okay. Now, coming to the first part of your question, in general, any gap, especially in the maxilla, if it is more than 5 millimeter, I would straight away put an interpositional bone graft. No second thoughts about it at all. Okay. Whatever may be the case, any gap more than 5 millimeter, I would go and put in a graft. That answers the first part of the question. The second part of the question, I don't have sufficient experience to say the long-term problems associated with procedures like this, whether the patient can have condylar resorption and things like that. I'm not very sure. As far as this patient is concerned, there are another 3 patients I have done counterclockwise rotation. As far as the stability is concerned, there is absolutely no problem as of now.
So you haven't used bone graft in these 3 patients which you have done?
I have. That's what I'm saying.
You have used the bone graft?
Yes, yes.
Okay. And
so it is not only in this patient, in any patient at present, if there is a gap of 5 millimeter, I would go ahead and put an interpositional bone graft.
Okay. The other one question is when you're doing the maxillomandibular rotation, the concept is usually maxilla first, and then we do the mandible we get the mandible back into the position.
Yeah.
Are there any situations which you have contemplated done using mandible first?
See, one of the things in the concept which I didn't address, or I thought I will not do it because there is a speaker after 2 days who is talking about sequencing. And sequencing is one of the talk you gave me in Belgaum a year ago.
Yeah,
If you're doing a clockwise rotation, listen to this carefully. If you're doing a clockwise rotation, then you have to do the maxilla first.
Correct.
Okay. But in any case, what I would do is I would go ahead and complete the cut for the mandible. Okay. Do all the cuts. I would not completely osteotomize it. Do the cut. Then go ahead and do the maxilla. Fix the maxilla. Put the intermediate splint. Okay. Because here you see the maxilla has to go up. Okay.
Okay.
If the maxilla has to go up, the maxilla should be done first.
All right.
If the mandible has to go down, the mandible should be done first.
Okay.
Okay. So for counterclockwise rotation, I will do the maxilla first.
Okay.
For a counterclockwise rotation, I would do the mandible first.
All right. The other question from the participants is that how many splints do you use in case when you are doing a counterclockwise or clockwise rotation?
All 2 splints.
All 2 splints. Yeah.
All bi-jaw surgeries, 2 splints without fail.
And how would you control the vector of maxillary rotation intraoperatively?
See, since I have the splint made properly, okay. Now, for example, I'm doing a clockwise rotation, okay. Okay. If I'm doing the clockwise rotation, I would more often rely on the computer planning, and in many of the cases, I would do it on a 3D articulator.
Okay.
So when it is in a 3D articulator, I know when I combine both these things, I know precisely the extent of the moment that is required. Okay.
All right.
In some cases, depends on where your point of rotation is. Okay. If a point of rotation is in the center, then you know, you whatever gap that you would get, I would use a bone graft. Okay. That I mentioned it earlier. So I would decide what would be my guide. The guide would be my intermediate splint.
All right.
My intermediate splint would dictate the amount of rotation and the guidance towards what I should do intraoperatively.
Okay. Whether would you use any external reference points?
Yeah, of course. I would see all. I would use internal points because I want to know how much the rotation is taken. I would always use vertical lines when I do the maxilla for rotation, because that will give me some guidance as how much it has rotated.
Okay. And you wouldn't do both the osteotomy maxilla mandible at the same time and then try to fix up all the segments? No, you wouldn't do it.
No.
Okay.
Mustafa, one question for you. There is a private message, so
yeah, I think we should speed up.
Yeah. What are the situations in which you consider doing maxillomandibular rotations instead of just anterior posterior movements? What are the
where there is severe paranasal hollowing, okay, and in some cases where the zygoma is where there is malar deficiency, then I would consider doing, and of course open bite. These are the indications. If there is an open bite, these are the indications for a clockwise rotation of the maxillomandibular complex.
Okay, I think we are
running short of time.
Exceeding the time. Yeah, let's go. Move on.
Mustafa sir, Mustafa sir, there's one question which has been popping up on
can we keep these questions to the end? In the end, we'll answer all the questions because we are going at a very snail's pace.
Yeah, let us move on.
Which I expressed yesterday. So what we'll do is, now let me have another 3 things to discuss. So at the end, we will only take 2 questions and we'll move forward. And the end, whatever questions we want, we can discuss it.
Fair enough. Let's go ahead.
Okay. Now, coming to the LR flare, which is a soft tissue change, which happens due to Lefort 1 impaction. Okay, increasing the LR width, upturning of the nasal tip, flattening of the lip nasolabial region, accentuation of the nasolabial groove, reduced vermilion exposure, thinning and of the lateral retraction of the lip, downturn of the mouth angle. Okay, now why this happens? Because of the periosteal elevation, which disinserts the facial muscles, particularly the nasolabial muscles and the anus. Then once you have done that, when you close the wound, the muscles tend to retract laterally, which will result in flaring, widening, and elevation of the base of the nose. This is one reason why the flaring happens. It need not be only if you do a superior impaction. Even if you have done a vestibular incision for a Lefort 1 fracture, you see it very carefully, there would be some amount of flare because the muscle tends to retract laterally. And that is the basis of this, what is called as a cinch suture, which we do for every case whenever we expose the maxilla. no matter what could be the reason. It could be a fracture or whatever. Then when you do an impaction of the maxilla, this is particularly pertaining to the impaction, there is a loss of pyriform dimension, because when you impact the pyriform, impact the maxilla, the entire pyriform aperture becomes smaller in its dimension. And there is also a tendency, a lot of people do that, they resect the base of the septum to accommodate, otherwise it will cause septal buckling, and that also can contribute to alar widening. What the triangle is denoting the pyriform aperture, so it loses its entire area and becomes smaller in dimension once you have impacted the maxilla. Okay, without dwelling much into sin suture and things like that. Say this is one case. See, after superior impaction, look at the nose. You know, it's become broader. So this is what happens when you impact the maxilla. There is excess septum, which very often gets resected. So what we do is we do a septal grooving without resecting the base of the septum. We accommodate the septum. We also do what is called as a pyriform plasty, which will be there mentioned in the video. And then we do the sin suturing. So it's a combination of 3 adjunctive procedures. That is alar sin suture, pyriform plasty, and septal grooving would reduce this problem significantly. Okay. And in my opinion, the best way to do is with the help of a submental intubation. Okay. There is enough literature. INSEE in 1996 recommended it for elective osteotomies. The main advantage is minimal intraoperative distortion of the nasolabial soft tissue. It also allows accurate placement of nasal sin suture to produce the desired aesthetic result. And the incisal show allows access to the other adjunctive procedures such as submental liposuction or platysmal plication if required. So what we do is we mark the incision for the submental patient when the patient is awake. We ask them to lift the head so that we can see the medial border of the mandible, and then make the marking before the patient is intubated. And it takes just exactly 2 minutes to do that. So these are some of the results after doing this procedure. If you look at the pre and post, there is no much difference as far as the flare is concerned. We have maintained the pre-operative integrity of the nose in terms of dimension and aesthetics. So these are a few of the cases. Okay. There are disadvantages of the submental intubation. Okay. Some say it will take additional 20 minutes, but in our hands, we have now in our center, we have done more than 300 submental intubations, and we have never had any problems. Okay. One of the contraindications could be skeloid scarring. In one patient of mine, 2 patients of mine, we had hypertrophic scar managed with steroids and things like that. Here are some of our results of the scar I'm talking about. The scar is hardly visible because it gets hidden under the shadow of the mandible. So if there is a hypertrophic scar, just use intradermal steroids, it will resolve. So now I will put in a small video quickly.
Yeah, Mustafa, while you're doing that, I have one comment to make.
Okay, sure. Please go ahead.
Your results are very nice and the scars are definitely invisible. But I would be very hesitant to make an extra skin incision for orthognathic surgery patients, even if we are doing bimaxillary osteotomies. If we are worried about the proper placement of alar-based sin suture, what Mr. Sugar, my teacher, used to do for the same reason, he used to pass the sutures while the patient was intubated, but he would tighten the sutures immediately after the patient is extubated for the same reason what you mentioned. Yeah, just a comment.
Not
Thank
that.
you.
Vestibular. Not that. Submental intubation. Submental intubation is there.
Abhay, what is your take on that? Do you do submental intubations for your bimax?
There. It is there.
I was a firm believer in nasal as we were conventionally taught, Dr. Vivek sir.
Yeah.
But after sitting in practice with Dr. Mustafa, now I have inculcated this habit of going into submental intubations.
Okay. What about Dr. Kotra?
No, I usually don't do submental intubation. I go ahead with the nasal intubation only, and I go ahead with the cinch by the standard way. I don't employ the submandibular or submental intubation. Sorry.
And the other thing, if I can tell, is sir spoke about the submental intubation and marking of the incision even before the patient is wheeled into the theater. What I've seen him do and what I've inculcated is in the pre-op area itself, he makes the patient sit upright and does the marking for the incision in the shadow of the mandible. So what happens is there's no distortion once the patient is on the OT table. So you get your markings exactly in the shadow.
I have an answer for that, a very good answer for that. I don't think so. Being a maxillofacial surgeon, you should worry so much about the scar, knowing very well that you have very superior skills in terms of suturing a wound. You know,
it's not just about the scar only. An additional procedure for the patient, if it can be avoided. I'm sure it works well in your hands, but there are many people who would like to avoid it.
Because it takes exactly 2 minutes to do that. You know, Abhay has seen me doing it's not, and these days I don't do it. My fellows do it, and they do it pretty fast.
Okay, let's continue with your video.
Okay, can I have that video? Forget that.
One question in the meanwhile, would you address the mentalis muscle separately when you're doing genioplasty? Because that would prevent the lip ptosis. I mean, similar to that of the LR cinching when you're doing the mandibular procedure.
Yeah,
something like genioplasty.
In some cases, I do that, you know, not in all cases. Sometimes what I do is I just do the soft tissue muscle draping in some cases without actually doing a genioplasty.
Okay, all right.
Can we go for the video?
Yeah,
sure,
please.
Sure.
Come, play the video. Yeah. Not that. Yeah. Play the video. You have to. Yeah. Can you all see the video? 1 minute. Can you
need
see
to
the video?
share it first. You need to share the content.
Share. You can see the video now?
Not
Can
yet.
you all see the video?
Not yet.
Not yet.
Yeah, now
Yes.
we are able to see.
Okay.
Play it now.
Yeah.
Reduces bleeding considerably. Subperiosteal exposure of the entire maxilla, followed by adequate reflection of the pyriform aperture, exposing the nasal septum. Marking of the LIFO-1 cut for better accuracy.
Dr. Mustafa? Dr. Mustafa?
Is removed to facilitate parallel impaction.
Mustafa sir, can you repeat the video, please? Because most part of the video didn't have an audio for our audience.
So you want?
Can you? Yeah. Drag back and repeat, please.
Recreate the preoperative dimension considerably. Subperiosteal exposure of the entire maxilla, followed by
Now the video is clear.
reflection of the pyriform aperture.
Yes, it's clear now. Thank you.
Exposing the nasal septum.
So the audio is very low.
Of the litho 1 cut.
Can you increase the audio output?
Yeah.
Incision of the maxillary third molar,
Improve
followed
the
by
audio
to facilitate
of the video.
third molar osteotomy. You can also make a separate vertical incision for better visualization of the vertical third molar cut. Litho 1 cut commences lateral to the pyriform aperture, all along the anterior maxilla and the zygomatic buttress.
Yeah, very clear.
Mustafa sir, you again muted the audio.
Muted the audio.
Six millimeter of bone is removed to permit the desired impaction. Curved osteotome is used to complete the cut palatally, followed by the down fracture of the maxilla with the help of a Smith spreader. Mild digital pressure to complete the down fracture. For complete separation, one can use the Rose disimpaction forceps. The remaining bone posterior to the vertical cut in the third molar region is removed to facilitate parallel impaction. Marking for the pyriform plasty. Pyriform plasty performed to recreate the preoperative dimension of the pyriform aperture. Followed by thinning the base of the septum and septal grooving to accommodate the septum without having to resect it. Fixation is done with the help of 4 titanium mini plates, 2 plates for the zygomatic buttress and 2 plates for the pyriform aperture, respectively.
You have to cut the video. I'll tell you where.
Vestibular incision. And the chin is exposed. Cut for the genioplasty commences from the midline, going below the mental foramen and ends at the inferior border posterior to the foramen.
Dr. Mustafa, you muted the audio again. You need to mute the video instead of muting the audio.
Conjunctive procedure. The nasolabial muscles are identified and anchored to a 3/0 nylon suture passed through a hole in the nasal spine and anchored to the nasolabial muscles on the opposite side. The knot is tied to complete the sin suture. Closure of the vestibular incision to complete the procedure. What we have achieved is.
Can you hear me? Hello?
Yes, we can hear you. Yes.
Okay. Okay. Is that okay? The video was fine,
Yeah.
I guess.
Yeah. Yes, it was
Okay.
fine. You can move on to the presentation,
Move
please.
on to the presentation. Okay. Discussion now.
Meanwhile,
Quickly,
when you're setting
2, 3.
up, Dr. Mustafa, when you're setting up the discussion, I just have one question. How do you manage a total concave profile? What is your experience in managing a total concave profile? You have gone through the entire gamut of rotation of the maxillomandibular complex. Hello.
Yeah. Okay. I heard that. So before we go into that, I would like to say this. One of the ways to do if the maxilla it's totally concave. Can you all hear me?
Yes, we
hear me?
can.
Yeah. Totally concave is to do a high Lefort 1 osteotomy. Okay. You can hear me?
Yes.
Yeah. You can do a high Lefort 1 osteotomy with extension, zygomatic extension and paranasal extension. The other thing, now this is a particular case where a patient had a previous history of trauma and things like that. He was very much concerned about his midface hypoplasia. Okay. And that's his CT. That's his occlusion. And look at how the concavity is, okay, in the paranasal area. Now, if I would have done a Lefort 1 osteotomy, look at what would have happened. I would have got a step there. If I would have done a high Lefort 1 and again address the problem, look at the diagram there depicted as 4. If I would have done again a high Lefort 1 and done a clockwise rotation, look at figure 5. If you want to break that concavity, then you have to divide the segment and do the anti-clockwise rotation of the upper segment and clockwise rotation of the maxillary segment. And that's what we did for this case. Okay, you can see that diagrammatic representation. Lefort 1 level, if I would have got it at a low level, what would be picture number 1? Picture number 2, high level, what would have happened? Picture number 3, high level and clockwise rotation, what would have happened? What I did is, I did a Lefort 3, okay, and a Lefort 1. And then the upper segment, I did an anti-clockwise rotation. And the Lefort segment, I did a clockwise rotation. So the upper part of the face, I did an anti-clockwise rotation. The Lefort 1 level, I did a clockwise rotation. So that is the 3D CT model. This is the intraoperative picture of a Lefort 3. So how I did that? I did the Lefort 3 1 first. I didn't down fracture it. Okay, made all the cuts, kept it ready. Then did a Lefort 3 disjunction, and then went and did a Lefort 1. And that's him. Okay. Now look at his mandible. Okay, I have something to say about this case, but I have achieved the projection of the midface. But if you look at the mandible, it is still, the steep mandibular plane is still intact. I should have got his chin more in a clockwise rotation of the chin, but what happened is the chin cut was placed much anterior to the mental foramen. This is something that I recommend when you do a genioplasty. Extend your cusp posterior to the mental foramen, just a little ahead of where your BSS or vertical cut is, because that will give you some stability in the posterior area, and you can move the genial segment the way you want with some amount of stability. Okay, so that's him. So that probably would answer your question. I won't go to this case. I'll go to the main presentation and finish it. Go to the main. Any other questions? One more question I can take regarding this LR cinch and things like that. I don't think so. There is, except maybe for whether to do a submental intubation or not. That is the contention. That's why my topic is evidence versus contention.
Yeah, Mustafa, one question.
Okay.
What is the difference in results when you use a regular conventional blade versus cautery? Because we have seen you using both.
Yeah. See, one is there is no much of tissue destruction when you use that. I use that Colorado probe because it's a very delicate, thin probe. Okay, there is no much of tissue retraction there, and you won't. There is no much charring of the tissue. It is minimal amount of heat that is dissipated, and very less bleeding when you use a Colorado compared to the blade. Okay. Earlier, I used to have
question. Which one you prefer, onlay bone grafting or a highly fought one, osteotomy?
Say, my experience with all the onlay bone grafting has been very poor, because most of the onlay bone grafting will subsequently resorb. Okay. So I would prefer to do an osteotomy rather than an onlay bone grafting. But interpositional bone graft, a big yes, always, for the sake of stability.
Yes. One more question. Does mucosal lip lengthening work? And what does literature say about this?
Okay. I have not quoted the literature. Of course, there are evidence to suggest that lip lengthening does have a positive impact whenever there is lip incompetence. But I would like to add one word of caution, especially if you're treating young girls. Some amount of lip incompetence and some amount of show is desirable. The reason is, especially among the female population, when they become older, when they cross their 30, there is a lip sag and lip lengthening. And if you do a little overcorrection, what will likely to happen is they will get that aged look. So a little bit of incompetent look, I would retain it in most of the female population, and a little bit of show. I wouldn't try and eliminate the show completely. I would maintain it.
One more quick question. Can genioplasty be an option for lower lip reversion? Describe the relation of genio to lip changes and upper lip lengthening.
Yeah, I have recently, I had a big debate with Pramod. The changes of lower lip eversion only by genioplasty is very minimal.
Okay.
Shall we move on?
Yeah,
I can privately share that literature.
Sure.
Surgery first approach. Okay. I don't think so. I have sufficient time to go into the complexities, but there is a rapid accelerating phenomenon in the near vicinity of where you have done the osteotomy. So it is more likely in the maxilla, comparatively less in the mandible, but the premise is your vertical osteotomy cut is in the area of the molars, and molars, first molar, second molar, and premolar are something which is a little late or has a delayed movement. So literature says it helps the rapid accelerating phenomenon if you do the surgery first approach. Okay, so I wouldn't go into all the literature, but what are the cases included? Class 3 malocclusion, skeletal open bite. The case that I showed where we did a clockwise rotation for an anterior open bite, we did surgery first in that. Okay, bimaxillary protrusion and facial asymmetry. So this is a case of, it's a sagittal problem, maxillary deficiency, mandibular excess. We did a surgery first approach for this patient. Okay, and we could complete the case in 8 months. That is one of the advantage of doing surgery first. This is a case of Bimax protrusion with VME. So we did a foot 1 AMO lower subapical genioplasty followed by orthodontics, and that is the outcome. Okay, asymmetry. First, we need to understand what asymmetry. So in simple terms, it is a skeletal excess or deficiency in the AP, I mean sagittal, vertical and transverse direction involving one half of the face. Okay, there could be a soft tissue component. Occlusal cant need not always be proportional to the degree of skeletal vertical asymmetry. So these are the points I want to make. And another point that I will bring into light is like how we spoke about maxillomandibular rotation, clockwise and anti-clockwise. In terms of cant, the same principles hold good. Okay. Now, if the center of rotation is in the mid-palatal region, then the maxilla can go up, or the one half of the maxilla can come down. Okay. But you can keep the center of rotation at the occlusal point and take one segment up, the opposite segment superiorly, or you can keep it at the occlusal point on the other side and bring the contralateral side inferiorly by keeping the point of rotation on the occlusal point. But if you keep it at the center, you can move it in either direction. So here is one case. Okay, this is the preoperative picture of that case. You see there is an occlusal cant, and in this you need to differentiate what is an upward cant and what is a downward cant. If the ramus is in excess, it is a downward cant. That means the maxilla has to go up and the mandible has to go up in that case. Okay, in such instances you have to do the now this is a case where it is a downward cant, because in this case it is one second, this is an upward cant. Okay, where the ramus is short on one side, so it is an upward cant where the ramus has to come down. So if the ramus has to come down, then you have to level the mandible first. So that's what we did in this case. Look at the X-ray. So this is a case of condylar hypoplasia where the ramus is shortened on one side. Okay. So it's an upward cant. So we did a face-bow transfer. You can see the cant there, the upward cant. Okay, so we level the mandible first and look at the splint there. That's what we did first. Okay, treatment plan, differential Lefort 1 osteotomy, right side sagittal split osteotomy. On the left side where the ramus was short, we did an inverted L osteotomy, and then we did a rotational genioplasty for this case. So this is the inverted L, which I modified a little bit, not a classical inverted L, so that the entire ramus component can come inferiorly. So that's the pre and post-operative picture of that patient. Okay. Again, in this case, we did surgery first. And that's the leveling of the occlusion, orthodontics going on. You can see how the ramus on either side is equalized. So in this case, the cant is proportion to the asymmetry, because the asymmetry is more vertical in direction and also in AP in direction. So that we corrected with genioplasty. Look at the PSF. So we have got the cant more or less corrected. Look at that. Okay. Now this is a case which is a downward cant, which happens in condylar hyperplasia or hemimandibular hyperplasia. There is increase in the length of the ramus on one side. So here the maxilla has to go up. Okay, on that side. If the maxilla has to go up, then you have to do the maxilla first. Otherwise, you can't push the mandible up. That is about sequencing. Okay, here is another case. She hemifacial microsomia. So she had a short ramus on one side. Okay, that's her preoperative. Look at the cant. This is an upward cant. So you have to bring that side inferiorly. Okay, that's the X-ray, PSF, and you can see in the lateral ceph the amount of ramus discrepancy between the right side and the left side. So the ramus is deficient by 17 millimeter, whereas the cant is only of 7 millimeter. That's what I was saying. The cant is not proportional to the asymmetry. So if I just move the maxillomandibular complex, I can only get a ramus length of additional length if I do an osteotomy of 7 millimeter. I have to compensate for another 10 millimeters. So you can do distraction in this case. This is one of the choice. Okay. So I won't go into all the skeletal problems of this case. So the diagnosis is tessier number 7 cleft with skeletal involvement, features synonymous with hemifacial microsomia. So we did a horizontal ramus osteotomy on the involved side, that is the right side, plus BSSO on the left side, inferior repositioning of the right side by 7 millimeter to accommodate the cant. So we put the intermediate splint, IMF, and fixation of the horizontal osteotomy with an interpositional bone graft. And we fix the BSSO. Then we put an elastoplastic implant there to get that additional length of 7 millimeter, a prefabricated med pore we used. Once we finished off it, then we did the downgrafting of the maxilla on the right side by 7 millimeter and put the final splint and did rest of the fixation. We also augmented the zygoma from the root to the eminence with the alloplastic material. Phase 2, we did an extended genioplasty with inferior repositioning on the left side and also a commissuroplasty. Okay, we have come till phase 2. Phase 3 would be fat graft because the hemifacial microsomia, there is a soft tissue component in that. So that is the computerized planning for that case. Okay, I have told you the sequencing.
So sorry to come in. Can you go a little slower, please? You're rushing through.
Okay. Okay. So let me go through the sequence first. What we did is we did a horizontal osteotomy on the right side. That is the involved side. You can see there. And we brought the mandible down on that side by 7 millimeter. And on the opposite side, we did the BSSO. We fixed the 7 millimeter horizontal osteotomy with an interpositional bone graft. Then we fixed the BSSO. And the additional 10 millimeter deficiency of the ramus was augmented with the help of an alloplastic implant. We used the med pore in this case. Once we have finished off with the mandible, then we went ahead and did the maxilla. So downgrafted the maxilla on that right side by 7 millimeter. You can see the gap there. Okay. And that's how we managed the case. In second stage, we did this advancement genioplasty with inferior reposition on the deficient side and also used an interpositional bone graft. So let me do the sequencing once again. Horizontal osteotomy, we fixed it. Okay, use the intermediate splint and fix the BSSO on the other side and put that alloplastic implant there and completed the mandible. Then we downgrafted the maxilla on the right side and then fixed it. You can see the bone graft there very clearly in the second picture. And then we used the inferior reposition of the genioplasty on the right side. You can see that big gap there, which we filled it within bone graft. And we also did the commissuroplasty in the second stage. And that is the result that we have achieved. You can see that gap there. That's her mouth opening. And you see we have corrected the cant. And we have got the necessary projection. Of course, she has a soft tissue deficit, which we are planning for a fat augmentation. Okay, any discussions here? Hello? Hello? Hello?
Mustafa sir, 1 minute. Co-host will come back to you. Just hold on.
Dr. Mustafa, only one question I have is, what about the stability, especially in the vertical plane?
In the vertical plane, in both those, in the mandible and the maxilla, should not be a problem because for the maxilla and the mandible, I have used bone grafts, interpositional bone grafts.
Okay. So bone graft would be adequate in all these cases.
Yeah.
Secondly, there is another one more question is, why genioplasty was done in the second phase?
Yeah.
Was one question which has been asked over here.
all asymmetric cases, as far as I am concerned, I would do genioplasty as a subsequent procedure. The reason is because if there is any residual asymmetry which is remaining, I can do it at this stage and correct it, you know, and some amount of AP asymmetry gets corrected when you do the maxillomandibular movements. So how much it is, we will not be able to assess properly if you're doing it in one stage. So wait, because genioplasty is a simple procedure. Of course, you will have problems in explaining to the patient. I explain it to them. I reassure them the second surgery is a very simple surgery. It will be finished within 1 day and you need 1 day's admission. So I've been able to convince that you can do it at one go, but I'm very concerned about the result because I can detect any residual asymmetry and correct it while doing the genioplasty. That's my answer.
All right.
Mustafa sir, one question here. Would you get all bone scans done for your patients who present with facial asymmetry? Is there a relevance of getting a bone scan?
All patients I would get, because it helps me to assess more objectively where the asymmetry is, and also helps me to analyze the cant. I can measure it in the CT.
I'm talking about bone scans. Bone scans.
Okay. You're talking about bone scans. Yeah.
Exactly.
Yeah. I would do it in, I would not do it for an hemifacial microsomia. Okay.
Right.
If it is other condyle related things like condylar hyperplasia, I would certainly do it. And you can either do a PET scan or you can do a SPECT scan, which is more accurate. So I have not, for obvious reasons, put a case of condylar hyperplasia in this series. So anything else?
And you spoke about the surgery first orthognathic approach. Where do you say, or where do you believe that RAP happens? Does it happen at the osteotomy site, or does it happen entirely around the process of the mandible?
I think I answered that question when I started with the SFO. Say, there is this big debate over, say, you're doing a ramus osteotomy. How do you account for the movement of the anterior teeth in the mandible? In the maxilla, it is self-explanatory because you have the osteotomy cut all around in the vicinity of the teeth. But in the mandible, that is the problem. So mandibular anterior teeth, this is what my orthodontist told me, it's not my answer. That mandibular anterior tooth movement is not such a big deal. It can even otherwise move very easily. The problem is the premolars and the molars. Okay, and that is in the vicinity of the osteotomy cut that you are making. So that explains it.
Thank you so much.
And I must say, there is a lot of debate on this. Some people say that it is a what do you call? It is a marketing technique. But in my own personal experience, I have been able to shorten the treatment time considerably with surgery first approach.
Vivek sir?
Okay. Yeah.
Vivek sir, any questions?
No, I was busy typing answers for other questions which need not be directed to the speaker.
I think we can proceed.
We can move on.
Yeah, we'll move on.
I want to get into the PPT. Just a second. Okay. Now let me quickly go through cleft orthognathic surgery, which is a big topic by itself, but I won't dwell much into it. But my opening remark for this would be a typical orthognathic surgeon who does a lot of orthognathic surgery, and if he is not doing cleft work, it would be a little difficult for him because you have to understand the dynamics of the soft tissue if you want to do cleft orthognathic surgery. That is one spectrum. The other spectrum is those who are doing cleft work and only doing cleft orthognathic and not doing a regular orthognathic will find it a little difficult to take into account the various movements, the maxillomandibular rotation and things like that. So ideally, you know, one who is doing regular orthognathic cases and regular cleft cases would be ideally suited to address this problem. If not, let us say it has been done by a orthognathic surgeon doing cleft orthognathic work, then he should closely liaise with the primary surgeon, because there is a soft tissue component to it. If you don't achieve a balance between the hard tissue and soft tissue, your entire cleft orthognathic work or the cleft skeletal work will be what you call as underperformance. So let me begin with the, hello, can I go to the next slide? I need, okay. So class 3 malocclusion is only just one indication of midface deficiency. So its absence does not mean that there is no cleft maxillary hypoplasia. So the manifestations can include the following areas, that is paranasal, nasal, infraorbital, zygomatic region, and occlusal levels. Okay. Maxillary deficiency contributes to the stigma of the cleft. How does it contribute? Because there is lack of normal cheek contour, there is nasolabial imbalance, there is lack of upper lip skeletal support, despite the soft tissues being perfectly matched. Okay, it may match, but the soft tissue, the upper lip will fall. This is the concern of most of the patients. The upper lip falling behind the lower lip. In a normal patient, is the lower lip will be in line with the upper lip, or the lower lip is slightly short of the upper lip. So in a normal patient, it is a negative lip step. So here it is a reverse. So when you say positive lip step, that means the upper lip is falling behind the lower lip. So this deficiency and deformity of the supporting skeletal tissue result in what is called as cleft maxilla, as we address today. But the ultimate aim, which many people may not agree, would be we want a good lip balance, because that would what will reduce the stigma of the cleft. Now, I am giving you a few case scenarios. Now, I asked this patient, what is your complaint? She said, upper lip falling behind my lower lip. So I asked the question, so what? I said, sir, it gives me a very aged look. The complaint with this patient, you ask any of the patient, do an intense interrogation, you would get this answer. Okay, what is the problem you're having? I said, sir, I'm looking older. Why do you look old? Sir, my upper lip is behind my lower lip. And it is the same complaint with this patient. And look at this child. She's just 9 years old and she looks like a very old lady. Okay, so one of the things that you can do is a simple thing. If the arches are well coordinated, you can do a Lefort 1 osteotomy and get the lip balance. That's the postoperative occlusion. If the deformity is enormous, let us say the negative overjet is more than 12 millimeter. This is one way to do it, is do an external RED. Okay, and that's the outcome. And you look at it, that is a wedding photograph. We have significantly reduced the stigma of the cleft for this particular patient. Here is another patient. This is not my own. This is Dr. Krishnamurthy and Dr. Preetham Shetty. I hope Preetham will remember this case, where they have used an internal distractor and got the maxilla forward. That's the placement. So few things I want to add. When you are doing an external distractor, one of the greatest disadvantages is the compliance, because the patient has to wear that appliance for almost 4 months. It is quite cumbersome, and there is some amount of relapse because of the pulling motion. Whereas internal distraction overcomes that problem. You know, compliance is not an issue. Okay. Only thing is to remove the distractor, probably you may have to do one more surgery, but compliance is not a big issue. Relapse is comparatively less. Okay, I won't quote the literature because I don't have the time right now. But one of the most important thing in an internal distractor is to maintain parallelism. That is, if you don't maintain parallelism, then you may land up with trouble. So say you can see that they have maintained the parallelism of this distractor to the other one, because it is 2 distractor on one each on either side. And this is the results they have achieved. I would say it's a fabulous result. Okay. Okay. much of the focus has been in looking at maxilla in a very isolated fashion, because a lot of them feel if you address the maxilla, the problem is solved. But this is not so the case with a bilateral lip, because in a bilateral lip, what happens is, look at this picture very carefully. That is, second picture is an operated bilateral lip. There is a circumferential difference between the upper and lower lip. So there is too much of strain on the upper lip. So that will result in the lower lip being everted. And that is the problem with the bilateral lip. Now here is this case. This case came to us, and we examined this patient. The skeleton appeared very normal. Okay, there is no maxillary deficiency per se, which is very evident and warranting an addressing of the skeletal problem. So she had very negligible or absence of a skeletal problem in this particular case. So what we did is, we did an Abhay flap for her, transfer that lower excess tissue, which is apparently excessive, onto the upper lip, and balance her upper and lower lip. And then we did a genioplasty on her because she had a lower facial excess. So skeletal problems are there. Look at the problem carefully and address the problem, what is there. If it is something very minimal, you can afford to ignore them. Now, if you look at this picture, you would not be able to say, somebody asked me this question, what is the change of the lower lip after genioplasty? See, those two pictures at the lower end, one is only after Abhay flap, one is after genioplasty. There is no significant change, and I've tried to assess this in most of the cases. So this is post Abhay, and this is post genioplasty. Look at it, pre-Abhay and post-Abhay. And this again, I've put the pre-Abhay in between. Post-genioplasty and pre-genioplasty, I've put it on either side. I don't think so you can distinguish between the two, which is before genioplasty and which is the post-Abhay. Okay, this is the cephalometric. I won't go into, there are a lot of findings that we have made, so I won't go into the, but the lower facial height has significantly reduced because of the genioplasty and in a anti-clockwise direction. Okay, there are, as I said earlier, there is a focus on the maxilla, but there are problems with the mandible which sometimes gets ignored, like the steep mandibular plane, increase in the anterior facial height, increased mandibular divergence, which Pramod was talking about. Okay. So inference is a better aesthetic result can be obtained with AP surgery of both the jaws. So you have to do a bi-jaw when you are encountered and when you observe problems like this. Advancement genioplasty will reduce the vertical facial height, thereby improving facial balance. So when I say bi-jaw surgery, maxilla could be either a Lefort 1 osteotomy or it could be an AMD. Okay, these are some of the other problems associated with mandible. Okay, short mandibular body, short mandibular overall length, short ramus, obtuse gonial angle, and things like that, which should not be ignored. So here is a case which we managed by doing a AMD and then doing a mandibular setback plus genioplasty. So that is post AMD. You see the maxilla has come forward. We have got a reasonable amount of positive overjet, but not a good profile. That is because the mandible is ignored. So we did a mandibular setback and a genioplasty. That's her. Okay, and we did a prosthetic rehabilitation for this case. This is another case with severe maxillary retrusion and crowding. So therefore, what we did is, phase 1, we did an AMD. So we gained additional space onto which we decrowded. And in the second stage, we did a maxillary advancement and mandibular setback. That's him. Okay. Of course, I should have done a genioplasty on this case, but he said, I'm fine with it. I don't need it. So that's the settling of the occlusion. And now this particular case, as I said earlier, it is not the class 3 relationship with the problem, because it can be in the paranasal area, it can be in the zygomatic area. So in this case, we didn't change the occlusion. All that we did is a maxillomandibular rotation. So you can see after the bi-jaw surgery, look at him. In a second stage, what we did is soft tissue correction. We did a lip revision for him. That's why I said you have to achieve balance between the hard tissue and the soft tissue. So that's the result that we got. Look at it, but we have not changed his occlusion. We have not moved in his maxilla forward or mandible backward. All that we did is a clockwise rotation of the maxillomandibular complex with genioplasty. Say his occlusion remains the same. That's his occlusion. We have not changed it at all. So that's him. So this is another severe case of secondary cleft deformity. Okay, she had a big fistula, which we managed with the tongue flap, and look at the shape of the arch. Okay, we did a good orthodontist did expansion. Dr. Ashik Utreja did a fantastic job. We did a bilateral bone graft, and then we did an RED for this patient and got the maxilla forward by 25 millimeter. After that, we did the BSSO. Look at the lip. We are still not getting the lip balance. And then we did, including an AMD. To get the lip balance, we did an Abhay flap because there is a volume deficit there, which is evident. You look at the lip carefully, you will notice that. Okay, this is the progression of the case. I'm just trying to highlight how important orthodontics is, and other specialties can help you. And that's her. Look at the changes after each of the procedure. See, at the age of 9, she looked very old with the profile that she had. Okay, we have advanced her maxilla by 25 millimeters. And look at the changes. See what changes I was talking about. Ultimately, it is we want a good lip balance, because that would give the aesthetics which is visible. Of course, there are a lot of other things because they may not be very visible to a naked eye. And that's her. Okay, this is after AMD, and look at the tongue flap from where she came and what we have achieved in terms of soft tissue and hard tissue. And that's her. Okay, so recommendations for mild CMH, cleft maxillary hypoplasia, if the arches are well defined, Lefort 1 advancement. If there is crowding, then do AMD. When I say mild cases, somewhere between 4 to 5 millimeters. Moderate, somewhere between 5 to 7 millimeters. If it's a well-defined arch, do a Lefort 1 and BSSO genioplasty. Moderate CMH with crowding, then do AMD, then BSSO and genioplasty. If it is more than 12 millimeter, you can think about a Lefort 1 distraction and block, plus BSSO if required, plus minus genioplasty. But in bilateral cases where there is a soft tissue deficit, Abhay flap is an optional procedure. Okay. Now, quickly, maybe 1 or 2 questions.
I think Kotra can ask questions. He does a lot of cleft work.
Yeah, Dr. Mustafa, one question is asked about by the audience is about any chance of relapse after around an year of the cleft segment. What is the incidence of relapse of palatal fistula after osteotomy, and how to prevent it?
Relapse of, what do you mean by relapse of palatal fistula?
I mean,
if there is a palatal fistula, there is a palatal fistula.
No, I mean, after the moment of the segments, if the fistula reopens, what should be done? And how
usually, I don't think so. Fistula should open up by advancing the maxilla. If there is a residual fistula, the fistula will become big when you do palatal expansion.
Transverse expansion.
I've never encountered a fistula becoming bigger, or if you have created a fistula that is iatrogenic, which can happen when you do a normal maxilla. But I have no experience in that. Second question.
Second question would be, in the red distraction, I saw in your pictures that the vector wires were coming out through the nasal cavity. So my question is, do you use a bone plate in the maxilla, or would you use a palatal plate and get your vector wires?
Say in that particular case, I used a plate and got it through the nasal aperture. I would not do that now. Correct. Now what I would do is I will directly attach the wire to the plate.
Okay.
I will not bring the plate out through the nostril.
Okay. So you would go in for a palatal plate, fix it up, and then get
not palatal plate. Not palatal plate. I would go in for bone plate and attach with the wire. I will not bring it out. I'll use the same thing, but I will not bring the plate out through the nostril.
What are your reasons for that?
It is not required. You can because this is a say you bring it out, there's too much of damage caused to the floor of the nostril. It is not required. It is unnecessary. You can pass a wire, bring it out with a small stab incision, which I learned from Pramod, and attach it to a wire, and then you can distract it, because RAD is basically pulling motion.
Okay.
Whereas internal distraction, it translates the entire maxilla.
Okay, that answers most of the things. I think unless there are any other questions, I think we can proceed ahead with the.
Just one question.
Yeah, I think there is one question.
There is a question which came up just now.
Yeah, sorry.
Is there any age criteria for performing anterior maxillary distraction, Mustafa?
Yeah, say you can do anterior maxillary distraction quite early, okay, as an intermediate procedure. If you see severe maxillary regression, we did it in one of the cases recently, because during their school going age, they can be quite stigmatized and they're very concerned. If that being the case, if there is severe retrusion, if there is severe retrusion, then you can do an AMD or any procedure for that matter.
Okay, thank you.
Not just AMD. You can do any procedure. I can quickly show you a procedure. Any other questions before I go there?
Last one question, Dr. Mustafa, is that there is a theory that during the second growth phase, you go in for distraction of the maxilla. Because of the growth potential, the outcomes of what you get of distraction are more optimal and the stability is better. Is that true in your experience?
Yeah, see, when I'm talking about AMD, I'm talking about an intermediate AMD where that AMD is not a definitive procedure, because AMD is a very simple procedure to do. So you do it as an intermediate procedure.
I'm talking about Lefort 1 and distraction.
Lefort 1 and distraction, Lefort 1s can wait, but sometimes maybe you may have to address a skeletal problem. Am I there on the screen? Can you see?
Yes, you are there. You are there. Yeah.
Now, that's the example I want to give. This patient was 9 years old with a severe maxillary retrusion. Okay. Now, the answer for your question lies if they have a concomitant functional problem. Now, this patient had two functional problems, which was quite grave, and the patient was very concerned. One is sleep apnea, okay, and one is hyperlacrimation because the orbits are not well supported.
Absolutely.
So we decided to do a Lefort 3 distraction for this patient. So that's what was done for this patient. Okay, that is the Lefort 3 distraction and the cuts that were made. Okay, we distracted. Okay, we used the biplanar distraction because the child required significant distraction. At the Lefort 1 level, we did around 30 millimeters, and at the Lefort at a higher level, we did it for around 15 millimeter. You would see here now the plates are not coming out. The wires are directly attached to the
cutaneous wires. Yeah.
Yeah, cutaneous wires. Okay, that's him. That's what we have achieved. Okay, and the hyperlacrimation has considerably reduced. Okay, and the airway space has considerably increased, and the OSA ceased completely. He didn't have any episodes of OSA after that. Okay, so this is one of the indications where you may, for functional reason, need earlier intervention. Not always. Otherwise, you can, if there is severe, retrusion, which is aesthetically unpleasant, you can do an intermediate AMD. Okay, that's him. Any other questions?
There was one more question which popped up about how would you manage the transverse discrepancy of the maxilla in cleft cases?
That is a pure orthodontic question. Of course, see, before we go into any of these definitive treatment for skeletal correction, if there is a transverse discrepancy, you should do a palatal expansion. Now, in one of the cases I showed, before I ventured into doing a Lefort 1 distraction, the orthodontist has done the palatal expansion.
Yeah.
Yeah, and given a, because arch coordination is very important. If the arches are not very well coordinated, which is an important factor even for surgery first, there is a high chance of relapse.
Okay, thank you. I think you can proceed with the lecture now.
Abhay, you have any question?
Any other questions, anybody?
Okay. Now, one point because since I bought an extra patient there, I will go to the same thing. I would now the same thing, Najat. Okay. Now, yeah. Okay. 1 minute. Now, this patient, when we did a 25 millimeter, he landed up with what is called as velopharyngeal incompetence. His speech deteriorated. This is one of the problems associated, not always, sometimes. Okay. So today what we know is that all the patients who undergo maxillary advancement will land up with velopharyngeal incompetence or speech deterioration. The answer is no. But if they have a borderline speech, then there is more chance of them going in for speech deterioration post-operative period. And this patient had a speech deterioration after 25 millimeters of maxillary advancement. Can I go to the next slide?
So there's one question, if you don't mind, if you can take one.
Hmm.
What about velopharyngeal insufficiency after the advancements?
That is what I'm talking. So this particular patient had velopharyngeal insufficiency aggravated by the maxillary movement or the midface movement that we have done. And the patient also had an additional anterior fistula, which was managed by the tongue flap. And then we had this case was done by Dr. Krishnamurthy. He did a furloughs on this case. He came to my unit and did it. And there was a significant improvement in the speech after we did the furloughs. I will quickly show you all the video of that, because people should know that one needs to be very careful in assessing the speech before you do cleft maxillary advancement. And these days I do it in all my patients. The audio. You can hear?
Yes, we can.
Okay, that is the preoperative post-distraction speech that the patient landed up with. Okay, now you look at the after we did the furloughs and closed the fistula, look at the speech. Can you hear?
Oh, yes.
Please play it.
The video is not shared, sir.
Okay. Sharing. Can you hear now? Can you hear?
Yes, sir.
I am coming from Calicut.
Enough.
4, 5, 6,
Come back to the original screen.
7, 8, 9, 10, 50, 51, 52, 53,
Stop it. Stop it.
55.
Okay. Did you all make out the difference between that speech?
Yes, Dr. Mustafa, absolutely.
Yeah.
Fantastic outcome.
Yeah. So there is always a way out. Okay. But the reason why I put that is one should remember that there is a remote possibility of speech deterioration when you advance the maxilla in cleft patient. Now coming
Sir,
to
one last question from the audience. Is
Yeah.
Furloughs better or pharyngeal flaps? I'm not into much.
That is a pure cleft related question. Yeah. So
Okay.
we will not answer that.
Yeah.
I'm sorry. Now coming to the last part of the thing is orthognathic surgery and ankylosis and TJR. Okay. Earlier the concept was to address the ankylosis and we should achieve mouth opening. That was the primary focus. As we went along, the concept came in because a lot of them realized am I in the screen now? Hello, am I in the screen?
Yes, you are.
And is the PPT on the screen?
Yes, very much.
Okay. So the concept was only mouth opening. Then a lot of it came in as a realization these patients do have obstructive sleep apnea, and therefore the onus shifted not just to achieve the mouth opening but also to correct the facial skeleton in order to correct the OSA. So earlier what people used to do is first do the release of the ankylosis only. Some of the patients subsequently, for various reasons, underwent skeletal problem. Underwent the correction of the skeletal problem. A lot of them were untouched. Then came the concept that we could do the ankylosis and the skeletal correction simultaneously. So during that era, I started doing this, what is called as a one-stage rehabilitation for patients with TM joint ankylosis. So here is this patient with zero mouth opening. Okay, that is the X-ray. You can see the antigonial notch. And one of the guys who popularized this is Al-Sheikh from Egypt. There is a great article by him. I couldn't get it. I had that article with me previously. It is there in the annals of maxillofacial surgery. So that is the nature of the deformity in terms of ankylosis and the facial skeleton. So what we did for this patient is we did a simultaneous functional and aesthetic correction. So how it is done? Gap arthroplasty, okay, on the involved side, then go to the contralateral side and do the coronoidectomy first, and you will get a mouth opening in most of the cases. Once you have done that, go ahead and do a BSSO on the contralateral side, bring the mandible forward, okay. Then if maxilla requires to be addressed in some cases, you can impact the maxilla. That's what we did in this case. We impacted the maxilla. Then we did all the fixation and then put a costochondral graft into that area where we have created the gap arthroplasty. So that is the outcome that we achieved. Frontal, see the amount of advancement that we could achieve by doing it in one stage. That's the radiograph, and that is orthodontic treatment. Okay, and that's her. Now, with the advent of TJR, there is again a shift in the way things are looked at. I will pass over to Dr. Abhay Kamath.
Am I audible?
Yes, sir, you are audible. Please, sir.
Yeah. Dr. Mustafa has already spoken about his protocol of management of TMJ ankylosis in a single stage. So what we did now was, since we have traveled a long mile, and now we had patient who presented to us with TMJ ankylosis. I would not go into much of the detailing. With nil mouth opening, and then the patient was subjected for a polysomnography as the patient's parents reported of the patient getting up in the night with frequent panic attacks. So we subjected him for a polysomnography, and the polysomnography report suggested of severe obstructive sleep apnea with an average saturation of 87% and an apnea-hypopnea index as low being as 50% to a rate of 29.8 per hour. So the patient was planned for a sequential surgery where we would first correct the obstructive sleep apnea with distraction or osteogenesis. Second phase would be release of the TMJ ankylosis and simultaneous joint reconstruction and correction of residual facial deformity with orthodontics bar orthognathic surgery. So he was scheduled for the distraction osteogenesis. This is how we plan for the evaluation of the deficiency. Once the deficiency is evaluated, we went ahead with placement of multi-vector distractors, and geometrically we assessed the pin placement angle on the mandible. And this is a cephalometric tracing as to understand what would be the final position of the mandible with regards to the maxilla and the incisor plane. This is a stereolith model which I normally get done, possibly to understand the pin placement angle so that we can construct a small stent, as Andrew spoke about this in the very first lecture when we started off this AOMSI web series. So we planned the stereolith model, and then we went ahead with the stents, and this was the treatment plan which was formulated, which is a standard treatment protocol as proposed by Lizrow. That's the osteotomy cuts above the angle and the multi-vector distractors being placed in position. And there you can see the post-distraction phase, the improvement of the entire facial balance and proportions being achieved. We ended up getting a vertical distraction of nearly 32 millimeters and an antero-posterior or a corpus distraction of nearly 22 millimeters. Post-distraction, he was again subjected to a polysomnography, and we found that his oxygen saturation was 97.6 with an apnea-hypopnea index, which was initially at the rate of 29, had come down to 6.8 per hour. That's his pre-distraction photos, and then the post-distraction photos. You see how well nourished he looks compared to his pre-distraction images. That's the lateral profile with the distractor in place and post-distraction after the distractors were removed. One thing I learned from one of my close friends, Anand and Pramod, is when we did the distraction, I kept the distractor for a longer period of time. There's no conflict of here. The very reason I'm saying this is because companies come up with the distractors where they have the carborundum rod for consolidation, whereas this distractor was left in place or in situ for nearly 5 months, so that I could get an enhanced quality of bone as I had thought in terms of a joint replacement. And this is the stereolith model what we fabricated for the patient to understand whether a stock prosthesis would fit into the area. Luckily for us, we had achieved a good distraction of the vertical ramus, and it was nearly 16 millimeters. So we could get away with the stock prosthesis on the same side. And the other component to understand the stereolith model was to know how the fossa component would fix into the skull base and the foot plate angulation, which is the most important component. The reason why we got this done was to see that the joint component or the foot plate would sit as posteriorly as possible, and also to know and understand what was the intraoperative difficulties we would face, as this patient was undergoing a joint replacement on a distracted mandible. Patient was posted for surgery, the regular preauricular and the submandibular approaches there, 2 separate sets of instruments so that there's no oral contamination. And there you see the joint replacement there, where the joint has been placed as posteriorly as possible to allow for the excess or the additional pseudo translation which can occur, which will not happen if you place the joint in the center of the fossa. So the most important component is placing the joint as posteriorly and as parallel to the posterior border as possible. Once we achieved a mouth opening of nearly 40 millimeters, we went ahead with an advancement genioplasty so that we could get the lip chin throat angle right and we could get a good contour there. these are the images of the patient pre-distraction, post-distraction, and post-TJR, where you can see a patient who's got good facial balance and proportions. That's his mouth opening sequentially, pre-distraction, distraction, and post-distraction. These are the images or the OPGs sequentially. The lateral cleft to show you and make you understand how the pharyngeal airway space is improved. And this is the CT scan where you see the post-distraction, you see the density of the bone and the quality of bone, what we have achieved, all in a vertical fashion when we use the distractor, especially the adult distractors where we get good density and good quality. So these are the images of pre-distraction and post-TJR. To summarize my presentation, what I would add is what Dr. Mustafa spoke is basically to deal with the conventional method of a single stage, as he spoke about the L-Shakes protocol, but the joint replacement has definitely taken us to a next level. And this is another patient where we took up this patient. In the previous patient, what we did was we did a symmetrical distraction osteogenesis, whereas this patient underwent not distraction osteogenesis, but she underwent gap arthroplasty and joint replacement. I would like Dr. Mustafa to come in and enlighten us.
Okay, can you hear me? I'll take 2 minutes for this case. Can you hear me? Can you
Yes,
hear
we can
me?
hear. Yes, we can hear you, sir. Please go ahead.
Yeah, this is the mouth opening of this patient who had a previous case, previous surgery for ankylosis, relapsed, and for almost 20 years she didn't open her mouth. That is the CT scan of the patient. So what we did for this patient is we managed the gap, we managed the deformity and the ankylosis and did the TJR and orthognathic surgery simultaneously. So we did the gap arthroplasty first, followed by BSSO on the other side. Okay, once that is done, onto that gap, we place the TJR. Okay, and inferiorly repositioned on that side because she had a cant of 7 millimeter. So total discrepancy was around 17 millimeter. So another 10 millimeter, like the previous case, came from the TJR. So the TJR also acted as to onlay an extended TJR we did in order to overcome or correct the ramus deficiency. So that is on the STL model, the sequencing of the case, gap arthroplasty, okay, BSS on the other side, then the mouth opening, and this is the pre and post result. This is our mouth opening. We, again here, genioplasty on the second stage. We're going to do it subsequently, okay. We're going to do the dental rehabilitation, but the most important point is see the amount of ramus length that we have gained by doing extended TJR prosthesis, because the other option for this patient would have been doing a distraction. So how much would you distract? You can distract only 7 millimeter. For 7 millimeter, the treatment would be delayed by another 8 months because you have to maintain the distractor and the post-distraction phase, etc., etc. Look at the ramus component that we have been able to re-establish. Okay, see that. So acknowledgement to all my orthodontists and my other surgical colleagues like Dr. Abhay, Kamath, Manu Prasad, Shreyas, and also my former orthodontists who have significantly contributed to whatever I spoke today. In the conclusion, okay, the true value of a man is not determined by his possession of truth, but the exertion and pursuit to get to that truth. And we always want to evolve, innovate, and this is what I would say. Innovation, if it doesn't serve mankind but himself, amounts to hubris. And in the end, I would say, if God were to hold all the truth in his right hand, and the left hand only signifies the drive for truth or the search for truth with the provision for errors, I would definitely choose the left hand. Thank you very much, ladies and gentlemen.
Hello, Vivek sir, please come in. Vivek sir and Kotra sir, please come in
Yeah.
for the final
Yeah.
discussion.
Final discussion.
Thank you, Mustafa and Abhay, for excellent and exhaustive presentations. Wonderful. Couldn't
Thank
be
you,
better.
Vivek sir. Thank
Couldn't
you,
be better.
Kotra sir.
Thank you all. Thank you
I'm
all.
sure it has enlightened all the intricacies to the younger audience and also the most experienced ones, because the variation in cases and the depth in the discussion was wonderful. Thank you both for great hard work and wonderful presentation.
Thank you, Vivek sir, Kotra sir, Mustafa
Yes.
sir. Thank you very much.
I also take this opportunity to congratulate Mustafa and Abhay for the excellent work. It was a swashbuckle century what you both did with your presentation, and the opportunity you had provided for all of us for an excellent discussion. And may I request Dr. Preetham Shetty to come in and go ahead with the concluding remarks.
Pramod, you're there? Thank you, Mustafa sir and Abhay, for a wonderful, wonderful lecture.
Thank you, Preetham, Pramod, Amit. I thank all my co-hosts, my speakers. Thank you very much.
Thank you, the co-host, Dr. Vivek and Dr. Kotrashetti, for a wonderful discussion over here. And not to forget our co-host in YouTube who have been answering all the questions there. Thank you, Padmaraj, and thank you, Jayesh, for the wonderful discussion you guys were holding in the YouTube. We asked for Orthognathic. As usual, Mustafa gave us a TJR free. It's buy one, take one free. But Dil Mange more. That's Dr. Mustafa. Over to you, Pramod.
Thank you all. So before we wind up, Amit, are you ready? Amit, are you ready?
Amit is unmuted. He's muted.
Amit, are you there?
Amit is muted.
What about the post-test, Preetham?
I want Amit to come in.
I'm here.
Amit, are you there?
Yeah, I'm there, sir.
Okay, can we start?
Yes.
Wait, sir. Can I just, there are some audience. Preetham.
Okay.
Yes.
Preetham, do we have the post-test?
Yeah,
post-test. They would want to stay
post-test.
back.
Elevenil is there?
Elevenil is here.
Yeah, Elevenil, do you have the post-test ready?
Let me unmute her.
Somebody has to.
I have unmuted her.
Not yet. Yeah.
Elevenil, do you have the post-test ready?
I'm trying. Praveen, can you unmute her, please?
Yeah, I'll do that.
So why don't we do this? Preetham, can you call Vernal in the time being?
Yeah, I'll do that.
While they finish that. So those who are interested in the post-test, please stay back. Okay, don't go away, please.
Okay, where is Amit?
I'm here, sir.
Okay, can we start?
Abhay,
are you ready? Yes.
Join us.
Okay,
I'm ready.
Okay, there we go. Chal ke tujhe main. One second.
Someone has to say 1, 2, 3.
1, 2, 3.
चल के तुझे लेके चलूं एक ऐसे गगन के तले
जहाँ गम भी न हो आंसू भी न हो बस प्यार ही प्यार पले एक ऐसी गगन के तले. Okay, thank you.
Thank you, Dr. Mustafa. We'll let you to sing more on the April 18th when we have the AOMSI talent search. We'll expose your talent there, more of your talents. Pramod, Elevenil is coming. She'll be ready till Elevenil comes back with her presentation. This is for all the PGs out here. You can please, for AMSI Got Talent, please record your talent and send to us 3-minute duration video. Please send it by tomorrow, 7 p.m. so that we can include it on the 18th April web series. Elevenil, are you there?
drag it. I have not used my.
Praveen, just check 11L. Yeah, she's there. Yeah.
But I'm not able to unmute her. She has to do by herself.
11L, can you unmute yourself?
Or you can, or she can just play. Or she can just play.
the audience.
She's there. 11L, unmute yourself.
Yes,
and
sir.
play.
Yes, sir. I'm already in.
Yeah,
Can't you hear me?
share. Yes, start the post.
1167.
Mentimeter. The code will be same, right? Mentimeter code?
No, it's a different code, sir. We
It's a
all know
different
that.
code. Okay.
It's a different code.
Sir has to sit there.
Request everybody else to mute the video and audio, please. Only 11L.
So can I start?
Go ahead,
Yes.
please.
There are about 17 participants. Are we expecting more?
Yeah, no, start.
just go
We
ahead.
won't
Whoever is there,
start. Just
go
go.
ahead.
Okay, I'm starting.
I can see 98 participants still there, so I'm sure they will join when you start the code.
Yes, yes. The first question is on, sir.
The code.
244029.
Your screen is not
Share
shared.
it. Your screen is not
Share
shared.
the screen.
Screen is not shared. One second.
Share content. Go to share content, please.
Yes, yes, I'm doing it, sir. Is it seen, sir?
Yep.
Yes.
Yes.
The code
Please,
is 244029.
So everybody open your Mentimeter. The code is 244029. We repeat, the code is 244029. Please open your Mentimeter app or download mentimeter.com and code is 244029. We have another 15 seconds to start.
We've started, sir. Already the question.
Oh,
is...
sorry. Okay.
I think, Preetham, we should give more time for this question because still people are trying to get in.
It will have 1 minute 30 seconds, sir.
Yeah.
Yeah.
That is good.
Okay, 26 have answered right. The correct answer is heavily compensated dental arches. Moving on to the next question. Time is up. 26 have got it right. So the correct answer is nasalis. Next question. So this is about the movements in which maxillary osteotomies are considered unstable over the others. There are different movements in different planes. Five more seconds to go. So 31 have answered it right. The correct answer is inferior and transverse movement. Moving on to the next. An inverted L osteotomy neutralizes the effect of which of the following muscles? Fifteen seconds to go. Only 10 have got it right. The correct answer is temporalis muscle. To the next question. Read it carefully. Rebleeding from the nose after the initial bleeding is controlled following a LIFO1 osteotomy. It is very typical of after the initial bleeding is controlled. Time. 13 have got it right. The correct answer is false aneurysm. Now to the next question. The ideal tooth exposure during smile is from full tooth crown to 2 mm of gingiva. So when you smile, we need to remember that tooth and gum exposure is decided by everything mentioned below except one factor. Time is up. Okay, 27 have got it right. The correct answer is maxillary occlusal cant. Okay, with this we come to the end of the quiz. Sir, we are done with this. Preetham, sir.
Thank you, Alavinil.
Thank you.
Thank you for this excellent quiz session. Pramod, are you there? So, hello?
Yes,
Yeah.
I'm here.
Yeah, let's conclude, right? Thank you, speakers.
Yeah,
Thank you,
let's conclude,
co-hosts.
yes.
Thank you for the wonderful session. It was 3 hours, 45 minutes. Dr. Mustafa was arguing with us. Praveen? Praveen,
Yes,
are
sir.
you there? Yeah, conclude.
Yes, sir.
Put the music and...
Hello?
All the hosts and co-hosts, a winding up session will be, hello?
Pramod, go ahead.
Yeah. We will have a small winding up session in as a different Zoom meeting. The ID will be sent to the WhatsApp group. Please join immediately,
Okay.
like yesterday.
Call.
Praveen, go ahead.